So first of all, I would like to say to preparing this program, and that especially in the research area is very important for acute care in our countries, not only our countries, as a nationality, including in African countries. The acute careness issue is what's need attention to be priority and that significant changes. Otherwise, still due to acute. Illnesses
Okay, good morning. Your Excellencies, Dr. Humphrey Karamagi and Dr. Leah Tadessa, and all our distinguished guest speakers, invited scientists and attendees all over the world. Welcome to this global virtual scientific conference entitled Building African Acute Clinical Care Research Capacity as a Priority in Global Health. This meeting is organized by the APORG Network for Perioperative and Critical Care in collaboration with the Ethiopian Ministry of Health, following the findings of ASOS and SOS and the intensive care studies in sub-Saharan Africa. It has been observed that there are few acute clinical research studies and research capacity is limited in sub-Saharan Africa. Despite these limitations, we have managed to produce very important clinical research for Africa. As a governmental, academic, and research organization that aspires to close this gap in Africa, the APORG University is delighted with the APORG-N4PCc initiative to ensure knowledge exchange and develop an experience sharing platform. I would like to say congratulations to the members of this committee and the APORG University, from which N4PCc grow, and a few words about NPCC. When it first started, it only intended to collaborate closely with primary hospitals in Ethiopia's northern Shoa region, but after realizing the potential and needs in other parts of Ethiopia, it began to realize the challenges and collaborating with other universities to establish a national clinical research network. Later, and after realizing the challenges and similarities in conducting collaborative clinical research in Africa while working with the African Cooperative Research Group, we began teaming up with the APORG to establish a Pan-African acute clinical research network in a wider perspective. So the evidence suggests that fewer clinical outcomes studies have been conducted in our African region, particularly on the COVID pandemic, where more research is needed. The only large collaborative study that examined the pandemic's impact was ACCOS, and African needs are more of the studies to understand patient outcomes in specific context and to be able to undertake a collaborative evidence-based quality improvement initiatives. In conclusion, the objective of this conference is to provide African clinicians and researchers with a forum through which they can share their research ideas, interact with and learn from the international experts, and prepare for large collaborative initiatives where possible. Thank you for supporting and joining this initiative. And at last, let me welcome our keynote speaker, Dr. Humphrey Karamagi, who is a WHO Acting African Regional Director. Thank you.
Thank you. Thank you very much for that warm introduction of health, Professor Fitsam, Bruce, and all our distinguished guests. First of all, I would want to appreciate the invitation for joining this discussion. I think this is something which is quite important in our view within WHO. We have a number of areas which we consider neglected. At present, most of the support is focused on particular areas. There is not a lot of support going into research, but specifically even if we're talking about acute care research, it's really a neglected area within the region. So really, we're quite happy to be part of this discussion, and we are looking forward to seeing how results will take us forward. It gives me great pleasure to address you during this event. We consider it a historical event in public health within the region. The event aims to provide African research clinicians and researchers with a forum through which they can share their research ideas, interact with and learn from international experts, and prepare them for the large continental collaboration that we require to move forward the health research agenda within the region. As WHO, we continue to support the member states on actions that will enhance the health outcomes for the populations in the region, in line with the mandate which the member states gave us. At WHO, our goal is to support member states to improve health outcomes through access to curative, preventive, promotive services, in line with what we are calling the triple billions target. So basically working towards ensuring that we have 1 billion more people covered under universal health coverage, health security, and under health determinants. Our strategic approach at present, the 13th General Program of Work, which I'm sure my team will manage, which I'm sure you are familiar with, gives us the thrust around which we focus the support that we are providing to member states. Consistent with this strategic approach is the need to ensure that critical care is an essential component of what we are providing in terms of support to countries. We have expanded access to critical care and improved quality of care across Africa, particularly in the context of the COVID-19 response, where we've provided a lot of support around the oxygen supply and so on. Therefore, welcome the work of this network and its potential to provide access to acute care that is quite critical for the health of our populations. Research and innovation, in our view, occupy a central position in the work that we and all the different health actors are doing. Within the context of COVID-19 and through the WHO solidarity studies, a number of different acute care therapeutics are being evaluated, even within the Africa region. As WHO, we've supported these networks to ensure that we are having the best possible evidence to guide the actions that are being carried out in the countries. For instance, we supported the studies on dexamethasone and other anti-inflammatory products during the critical care process with regard to COVID-19. In collaboration with partners, we constituted the Regional Expert Advisory Committee on Traditional Medicine for COVID-19 response, what we call the REACT group. And the aim of establishing this REACT was to provide independent scientific advice and support to countries on safety, efficacy, and quality, particularly of medical products that and therapeutics that are generated within the region, and to support countries in collaborative efforts to conduct clinical trials of medicines in compliance with international studies. And we think that this example of this REACT collaboration is a good way of showing getting local products, local expertise, and being able to apply them in a scientific manner to the benefit of our population. We have also seen this, or we have been doing this way before COVID-19 with respect, for example, to the Ebola virus disease outbreak. We did support a number of studies on monoclonal antibodies, convalescence plasma, and therapeutics in a number of the Ebola treatment units in Guinea, Liberia, and Sierra Leone and the DRC. And as a result, we have a number of good research networks around acute care. For example, we have the West African Consortium, which currently has been doing quite some good work in this area. As WHO, we look at our role as bringing experts together, enabling you to be able to know what are the important questions being asked, help facilitate the conduct of this research, but also help with the disseminating of the information that comes out from this research. And really the area around acute care is quite crucial at present. It is an area which has traditionally been ignored, but I think from the experiences we are seeing with the current threats that countries are facing, there is quite a stronger emphasis on it than has been placed before. We also help to convene the experts who are able to evaluate the evidence that is emerging for the use of therapeutics and other interventions. And these recommendations, then we facilitate the dissemination, their dissemination among member states and policymakers to ensure that there is an appropriate policy environment to take up what is coming from the research. We have provided consultants, we provided training to boost the capacity in acute or critical care capacity, and also helped with the adoption of appropriate policies, particularly in the context of universal health coverage attainment. However, we do recognize that there's a lot more that needs to be done to really move forward the area around acute and critical care in our facilities, and especially around research in acute and critical care in our facilities. We need really to integrate research and critical care much better. And it's not just something that is done, that they are not just things that are done when they support, when they are partners, but rather they become a part of the day-to-day work that we are doing as actors in this area. We need to look at how we can build the required capacities in the countries. We know this is quite low, and many of our critical care facilities or services are really not designed for research. And these are things that we need to be thinking about changing. I want, therefore, in conclusion, to thank the organizers for this very interesting, very important invitation. This is quite important. Building African acute care research capacity is a priority for us within the region. And we have noted that the countries within the region have really not been strongly involved in the various research efforts relating, for example, to COVID-19 pandemic. We hope that within this meeting, we'll be able to discuss and see ways that we can strengthen our involvement, our researchers within the region in acute care and making sure that we are able to get the required evidence from our own teams that is needed to guide this crucial area forward. I will stop here and thank you once again for the invitation to WHO and for taking time to listen to us. Thank you.
Thank you, Dr. Humphrey Karamagi. And now I would like to invite Dr. Leah, Ministry of Health, from Minister of Health of Ethiopia.
Thank you very much. Greetings, everyone. Honorable Dr. Humphrey Karamagi, WHO Representative, AFRO's Assistant Regional Director, respected organizers of this important conference from the African Preoperative Research Group and Deborah Burhan University and other organizers. It really gives me a great pleasure to be here with you today and address this conference on building African acute care research capacity as a priority. When we look at what it takes to build a responsive and a resilient health system that can serve to ensure equitable access and highest quality of care to its client and to its community, we all know that there are many pillars to address this huge challenge. But I would definitely say that having a culture of continuous system design and evidence-informed decision-making lies at the heart of this process. And this does require a focus to build the research capacity as a priority area in global health, which is why we are all here today. In Africa, where the provision of adequate health service is a challenge, the delivery of acute care and ICU service is really far from what's required. And the outbreak of the COVID pandemic and other emergencies have made those health service constraints even more worse. As it is evident, the shifting trend in the global burden of diseases has also shown the greater need to invest on the acute care system. And this has been similar in countries like Ethiopia and in parts of Africa. As a Minister of Health, Ethiopia's Minister of Health has been leading several efforts to strengthen services in the acute care continuum, including starting from the pre-hospital services, the facility-based services, including up to the rehabilitation, the referral system, having a strong referral system, disaster preparedness and response, as well as developing the workforce for emergency and the critical care. And this has been clearly outlined in our policies and strategies and given due emphasis as reflected in the National Emergency, Injury and Critical Care 5-year strategy we launched this past 1 year. And with these efforts within the COVID pandemic, which we have been able to increase ICU capacity nationally, where we now have around 59 ICUs in 59 hospitals, public hospitals in the country, increase the bed capacity and health workers, and planning to expand the services in different parts of the country, and also other key elements like expanding oxygen production, which we all know is very critical for this service. And one initiative worth highlighting is our Major City Emergency and Critical Care Improvement Program, MACIP, which creates linkage between university hospitals, regional health bureaus, and city mayor offices to jointly implement a customized high-impact intervention in the acute care continuum and generate local evidence to improve those cares, and currently being implemented in 8 cities. However, even though there are these encouraging progresses, the gap is still huge in addressing the demand with still the low number of ICU bed per 100,000 population, shortage of emergency and critical care drugs, supplies and equipment, and also the shortage of needed well-trained human resources. There is also a paucity of data and evidence around customized high-impact interventions to suit the demands of low and middle income countries like Ethiopia. So there is indeed a greater need to generate quality evidence and base our strategic decisions on these evidences and institute sustainable change more than ever. And this clearly requires a strong research platform, but also requires investing on strong health information system at all levels in our facilities to get the quality data that's needed to generate those evidences in a regular basis. So it's very crucial to exchange views on how to strengthen our acute care service and create the local capacity for research at this juncture. And this is, I believe, should be done in collaboration with different stakeholders and institutions like universities, research institutions, subnational and national health offices, partners, and other stakeholders. And I believe today's platform would create the opportunity to exchange experience, provide new insight and valuable input to the already initiated efforts, and also enhance strong foundation for the collaborative work across Africa and beyond. And I would like to reaffirm the interest and commitment of the Minister of Health to translate evidence into policy and work in collaboration with these groups. And we have to remember we have miles to go before realizing the overarching objective of improving the health and well-being of the population. And I would like to urge everyone to join hands in evidence generation and collaborative work in the acute care continuum for healthier, productive, and prosperous society. Finally, I would like to thank the conference of organizers for bringing this timely agenda into the table, and wish all participants to have a productive conference for today and tomorrow. It is indeed time to build Africa care research, acute care research capacity as a priority in global health. Thank you very much.
Thank you, Dr. Leah, for a nice explanation of our current situation in Africa as well as in Ethiopia. And currently, next I would like to invite Dr. Turnesh.
Thank you for the invitation. So I will be chairing the sessions after now. I will chair the first session with Professor Rupert. Professor Rupert Pierce was graduated in 1996 from St. George's Hospital Medical School, London, UK. After a time of working in general medicine and anesthesia, he returned to St. George Hospital, where he developed many of his current research interests and completed his training in intensive care medicine. In 2006, he was appointed senior lecturer in intensive care medicine in Queen Mary University of London and was promoted to professor in 2014. He has now given up anesthesia to concentrate more on the critical care. And he's now working on an adult critical care unit in the Royal London Hospital, and his research into improving patient outcomes following major surgeries. Robert has played a leading role in a number of large multi-center trials and had a growing interest in global health research, including as a chief investigator of a major global health trial of high versus low oxygen concentrations in major abdominal surgeries. I will now invite Professor Rupert to the stage. Professor Rupert, you have 30 minutes to present on what is global health, why is it important, and also what percentage of it is an acute care. And we have another 10 minutes of discussion. So for those of you who has questions, use the chat box to write your questions, or you can also direct your questions to Professor Rupert after the presentation directly. For those who are attending from the meeting hall, please forward your questions to the representative so you can get an organized question. For those of you who are attending individually, you can raise your hands on the view, so on your video, so we can pick the people who have raised their hands. Professor Rupert, you're welcome. The floor is yours.
Hello. Ooh.
There seems some inconveniences. Sorry for that. I can't see Professor Rupert on the stage. So let's now go to the next session. The next speaker will be Professor Bruce Ricard. So Professor Bruce Ricard is a speaker for what is global surgery on this stage. So he is a second chair in the Department of Anesthesia and Perioperative Medicine at Groote Schuur Hospital and the University of Cape Town, South Africa. His research interests include perioperative medicine, perioperative outcomes, and global surgery. He's a proponent of international collaborative research. He collaborates with the African Perioperative Research Group, APORG, where he has led the African surgical outcomes, like the ASOS 2 trials, and he has also co-lead the COVID-19 critical care research that we just did, the ACOS research. So Professor Bruce, welcome to the stage to speak on what is global surgery. And we have
Thank you very much.
20 minutes for this presentation. The same thing applies.
Thanks a lot. Thank you for this invitation this morning. Thank you to FITSIM and the N4PCc team, and to the WHO African region, and for the Ethiopian Ministry of Health. Thank you all for allowing us this opportunity. FITSIM has asked me to address the question of what is global surgery. And a lot of the talk I'm taking today is based on a lot of the educational work that the Global Surgery Division at the University of Cape Town, the educational component as a foundations course. So it's based loosely around that. For people interested in global surgery, there's the link to their educational activities, which I would strongly suggest you explore. So I'm going to chat about 5 things. What is global surgery and unmet need for surgery? A bit about the Lancet Commission on Global Surgery and Surgical Outcomes in Africa. Social determinants of health and health equity, the surgical pathway and bellwether procedures, and health system strengthening and quality of care measures. Just some disclosures on funding. So as an introduction, we've been involved in ASOS, ASOS2, ACOS, and APORG, which is the network of clinical researchers across Africa. ASOS, we received a little bit of funding from MRC in South Africa, but essentially the study was done unfunded as we received the money after the study. ASOS2, we had a sub-grant from Bill and Melinda Gates, which essentially was about $1 per patient, and that was used to manage the database and the data administration for the study across Africa. Again, the database for ACOS was supported by the Critical Care Society of Southern Africa, and the Evidence-Based Perioperative Medicine Group raised funds for a database for APORG across Africa, and the beta version is running, and you'll hear a bit more about it tomorrow. So what is global surgery? So it's an area of study, research, and practice and advocacy that seeks to improve health outcomes and achieve health equity for all people who need surgical, obstetric, and anesthesia care. And there's a special emphasis on underserved populations. If we look at health, about 1.3 billion people don't have access to the most basic healthcare. And if we look at surgery, the Commission suggested the following: there are about 5 billion people who lack access to safe and affordable surgery. We need about 143 million extra surgical procedures per year. And there are about 33 million people at risk of catastrophic financial burden. That's defined as more than 40% of your net income per annum. We need to think about health equity in global surgery because, often people talk about improving longevity, falling maternal mortality, increasing childhood survival. But the reality is that's talking about equality. Equity is really thinking about patients having access to the same resources or resources needed to achieve similar health outcomes. And I think the work that we've all been doing in Africa demonstrates how little equity there is in health and particularly in acute care in Africa. And this really is what we need to be focusing on. We need to focus on health equity for our patients. So there are a number of determinants of quality surgical care. So there's social determinants of health, and then I'm going to chat a bit about Don and Bedian's principles of quality surgical care. So social determinants, these are the non-medical factors that influence health outcomes. They've got to do with where we're born, where we grow up, where we work, live, and get old. And these are the sort of systems which shape our daily life, and they also affect our health. And there are a number of things which determine this, and it's economics and social norms and policies and politics, for example. If we look at Don and Bedian's principles of quality of care, what we see here is that the structure of the care and the process of the care determines the outcomes for our patients. And so structure talks about resources, both physical and human. Processes are what happens around the care of the patient. And there are a lot of things that we can think about when we think about structure and processes, and they're all, we can think about them as how do we use them for advocacy, how do we set up regulatory requirements to ensure healthcare is better, how do we finance the health, how do we track this quality of care, what education do we provide for our patients. For essential surgery, the Lancet Commission defined 3 bellwether procedures. This was the midline laparotomy, cesarean delivery, and the treatment of an open fracture. Now, they defined these as the requirements for a hospital to be able to deliver surgery. They should be able to provide these 3 surgical procedures. The DCP3, and that QR code is actually to the essential surgery DCP3 book, which you can readily download for free. It's excellent. They define 44 surgical procedures, which they considered extremely cost effective. So, I mean, these are really the places we need to start. We need to ensure that our district general hospitals, which provide surgical provisions, can provide the 3 bellwether procedures. And the first 44 procedures we need to focus on are those listed in the DCP3 guidelines. The next thing is looking at access to surgery, ensuring that the patient gets to surgery quickly and that the health system is functional through the community to the primary healthcare center, to the first level of district hospital, and then to a higher level secondary and tertiary hospitals. So really, we need to capacitate the first level hospitals or district hospitals to be able to provide bellwether procedures. And we need to ensure that the patient pathway to that district hospital is clear and quick. So how do we improve global surgery? And this really is looking at how do we strengthen our healthcare systems and how do we determine a minimum level of quality of care. Healthcare system strengthening, I think we've had great work from the Lancet Commission on this. They set out these indicators, which are benchmarks for what we need to do. Access to timely essential surgery, and there's a definition for that. There's a definition for the specialist surgical workforce density that we need, the surgical volume that we should be trying to achieve annually, that we should be tracking perioperative mortality so that we know how we're performing, and finally protecting the patients against catastrophic expenditure for accessing surgical care. If we look at Africa in the light of this, of healthcare strengthening, these are the data from ASOS. What we see is we have less than one specialist per 100,000, a specialist being either an anesthetist, obstetrician, or surgeon. And the recommendation, based on data supporting increased survival for maternal mortality or for mothers at the cesarean delivery, is about 20 to 40. So that's the target. And how far are we off? It varies between about 20 and 50-fold less than the minimum requirement for safe surgery is the number of specialists we have. And you can see the surgical procedures are at the hospitals are tiny, and we should be targeting about 5,000 procedures per 100,000 patients, and we're way off that in Africa. So if we look at the surgical specialist workforce, surgical volume, and perioperative mortality, this is what we see. So the first thing we see is there's an inflection point for maternal survival with cesarean delivery, needing about 20 to 40 specialists per 100,000. And this is the data from ASOS, less than one specialist per 100,000. If we look at workforce density from anesthesia providers, we need about 4 providers per 100,000 to achieve that inflection point of safe cesarean deliveries. Africa runs at essentially less than 1 per 100,000 across the continent, and this is not necessarily physicians. These are all individuals providing anesthesia. So you can see we're way off the workforce density we need. If you look at surgical volume, so what we've done here is we've taken the data from the surgical outcome studies, ASOS, ISOS, USOS, and from the global surgery studies as well. And we've used that data to get an idea for volume of surgeries across countries. And if you look at the target of 5,000 per 100,000 as per the Lancet Commission, what you see is only once you're high income country do you achieve this objective. Most of Africa is low income and low middle income countries, and the volume of surgery that needs to be increased to achieve these objectives is huge. In the low income countries, we estimate that you need to do 25-fold more surgery to get to 5,000 cases per 100,000 population. These are the data just shown graphically for African countries from that data set on the volume of surgery per 100,000. On the right is the United Kingdom, as they actually do run almost at 5,000 cases per 100,000. But then for the rest of Africa is below. Botswana just over 3,000, Namibia, South Africa at about 2,000, and then you can see it tails off very quickly, which is obviously extremely disturbing. What about surgical outcomes? So we talk about benchmarking and perioperative mortality. So what you can see in front of you here are surgical outcomes in global studies. So in vision, the 30-day mortality, that's all surgeries in adults, runs at about 2%. If you look at ISOS elective surgery, in hospital mortality about 0.5%. If you look at children, APORG, a European study, 30-day in hospital mortality about 0.1%. And if you look at cesarean deliveries from the NESQIP data in the US, maternal mortality of 0.01%. So these are data from Africa and South Africa. Look at ASOS, all surgeries, 2% in hospital mortality, and elective surgery, 1% in hospital mortality. You look at SAPSOS, which was a South African pediatric surgical outcome study, in hospital mortality of 1%. The study, which is just starting now, ASOS Speeds, is the consequence of SAPSOS. SAPSOS was what we would call a pilot. We had about 60 hospitals in South Africa, and through the findings of SAPSOS and refining the data set, now we're running the ASOS Speeds project across Africa. And then finally, the cesarean mortality in Africa, you can see in-hospital mortality of about 0.5%. I think this is the scary part, is if you look at the comparable outcomes, we see that if you have surgery in Africa and you're an adult, you're twice as likely to die. If you have, if you're a child and you have surgery, the South African data suggests that you're 10 times likely to die compared to what happens in Europe. And if you have a cesarean delivery in Africa, you're 50 times more likely to die than in the US. That is actually the bottom line for perioperative mortality in Africa and South Africa. So we got a big challenge. So if you look at perioperative mortality rate, so from ASOS, we know that the mortality following elective surgery is twice that of the global average. And what we see is that the mortality following complications is also twice that. That means if you die following a complication, it's known as failure to rescue. And this is the important part about acute care, is that if you develop a complication in Africa, you're twice as likely to die from it. So there's this failure to rescue of double that of the global average, and this is certainly a real worry. So, you know, how can people get involved in global surgery in our context? So there are a number of things that we need to be focusing on. For governments, the challenge is to provide the NSOPs, National Surgical Obstetric and Anesthesia Plans for the country. This is to create the infrastructure and the support to provide an environment for safe and affordable surgery. And governments need to look towards financing surgery, especially because it's cross-disciplinary, and it provides other skills to hospitals for the provision of acute care. Again, funders play a big role, and they need to play a bigger role in supporting surgical funding initiatives. And the reason I say this is because when you look at mortality globally The third most common association with mortality are patients who've undergone surgery within the previous 30 days. And that's higher than HIV, malaria, and TB combined. Civil society, I think, has got a big role to play in this. And this is really I apologize. I got dropped off by the network. This is my last slide. So in conclusion, I think we've got the global surgery principles to guide us. It's clear that we have unacceptable surgical outcomes in Africa, but I do believe, through APORG and through the N4PCc and the support shown by the Ethiopian Ministry of Health and by the WHO African region, that we really do have a network with the capacity to improve the quality of surgical care. So thank you for this opportunity.
Thank you, Professor Bruce, for the presentation. Now the floor is open for questions, discussions, and opinions. I can't see any question on the chat box.
If there are no questions, I'm happy for us to break for tea.
Oh, okay.
Maybe I can just make one more comment. I think, when we look at the outcomes, surgical outcomes in Africa, they're obviously very distressing. I don't think that should make us despondent. I think as a group, we're doing fantastic work. We are highlighting a very important area that needs to be addressed. We're responding appropriately. In other words, we're looking towards strategies to improve the quality of surgical and acute care in Africa. So personally, I think, although it's very distressing, what I've shown you, I think it's extremely important. So thank you all.
Thank you for the additional opinion. We have one question from Lucan Tasama. The question is to everyone. What are the strategies to implement telesurgery technology in Africa, especially Ethiopia?
Should I have a go? I know there are others on the group who probably will have very good opinions on this. So just from the perspective of APORG, so, you know, APORG started with just trying to understand what's going on, you know, in surgery in Africa. And we're certainly getting a very good idea quickly. And I think once ASOS PEDS is complete, we'll have a very good idea of all surgical outcomes, children, adults, and mothers. And the second part is certainly we're looking at strategies, you know, what can we do to improve quality of care? And part of that was ASOS 2, looking for simple, generalizable interventions to improve quality of care. I think what ASOS 2 has shown us is that improving the quality of care is it's complex. It's a complex intervention, basically. And so that comes to the answer to your question about telesurgery, etc. So certainly part of the findings of ASOS 2 comes down to communication. Communication and I would say telehealth is part of that network of communication. So it's a space really that we as a group haven't worked much in yet, but certainly I think it's probably an area which will quickly become part of the strategy of trying to improve quality of surgical care in Africa, and different strategies for communication of surgery and surgical problems and surgical care. I don't know if anyone else wants to ask or comment on that question, or I'm happy to go to the next one from Tim Baker. Trunesh?
Yeah. Anyone? Additional idea? No, so let's go to the next question, Professor.
Okay, so Tim asks, how can efforts to improve global critical care learn from the progress by the global surgery efforts? So thanks, Tim. So I think the point, I think where what's been really good for the global surgery group was firstly the Lancet Commission and setting those standards. So the six indicators, which are now 5 because they've collapsed the 2 finance indicators. But setting the indicators gives one targets to work towards. I think that's extremely important. And to be honest, it was one of the impetuses which resulted in ASOS and APORG. Was at the time, I think there were a lot of us who were really interested in what was going on, but the Lancet Commission gave direction. And the first thing was such a simple thing is, you know, how many people die after surgery? And the reality is, at the time, we had no idea, which led to ASOS. And so I think, you know, as soon as one's got common indicators that one wants to deliver globally, that's important. And then trying to answer them. And what's happened, I think, in Africa with us trying to answer some of these very simple questions is that we've built a network of clinician investigators who are invested in this and are really keen to improve the quality of care. And that is really, I think, what's been tremendously important for all of us. So there's another question on task shifting. Do you want me to address that?
Yes, please go to the next question. I don't see any hands raised, additional ideas.
Okay. So task shifting and task sharing, the concepts of providing healthcare by either non-specialists or non-physicians. So I think if you look at the slide I showed of specialists per 100,000, and us in Africa having less than 1 per 100,000 surgeons, obstetricians, and anesthetists, and we should have in the region of 20 to 40. To be able to get to that point is going to be impossible with physicians alone. So if you want to increase access to surgery, we have to embrace the concepts of task sharing and task shifting. So really the issue here is about how do we create an environment to be able to provide safe surgery and anesthesia when one is talking about task shifting and task sharing. And so formalizing training programs and trying to set up structures in district hospitals that support non-physician surgical and anesthesia providers is extremely important. I think one of the great papers to read on this topic is a documentation of the Tanzanian NSUB process. So in that NSUB process, they targeted a 25-fold increase in anesthesia providers over a 5-year period based on an increase in anesthesia physicians and anesthesia non-physician providers. So looking for one to support the other. And that led them to a total predicted anesthesia providers for the country of still only 2.5 per 100,000. And remember in my talk, I said we need 4. But this is a massive increase in surgical capacity, 25-fold increase. So again, at the end, we spoke about what can we do? Well, NSUBs is super important, but the experience, our knowledge of the workforce, and the example from the Tanzanian NSUB shows us that there has to be a place for task shifting in these plans. But it has to be also, we have to set a structure which allows for safe task shifting. And I think the Tanzanian NSUB is a very good example of this.
Okay, thank you. There are still more questions, but we have some announcements. Dr. Leah, Her Excellency, the Ministry of Health head has left, but there are the Ministry of Health members who are still there to answer our questions. If there is any question or concern that we should raise to the Ministry of Health of Ethiopia, there is also from the APORG-N4PCc. It's also that this platform is also running on a YouTube, so we can connect from that. The link has been shared on the chat box. There are more questions, Professor Bruce. What do you think and what has to be done to improve this great gap, particularly in Africa?
Which question are we looking at?
It's the one saying the there's of implementational research in the regard about the research assessing patients' outcomes related to surgery and anesthesia. You've seen the question from Azmara Ambacho.
Oh, okay. Okay, so yes, I think that's a very important question. So Asmara says there are plenty of research assessing outcomes related to surgery and anesthesia, and I agree. I think we've been doing a lot of that, and as I said, the most important area which we still do not know about is the children. And then it says, however, in my opinion, there's a dearth of implementational researchers in this regard. What do you think, and what has to be done to improve this great gap, particularly in Africa? So SOS2, which I think I will touch on in one of my next talks. But anyway, what we tried to do was try to address failure to rescue quickly and generalizably across Africa. And we thought if we could do this, we will at least improve some of the quality of the perioperative care and we'll decrease mortality. The simple answer is we didn't manage to decrease mortality. And it came down to exactly this question. It came down to implementation. It appears that even in what might be considered a simple post-operative intervention, the environment in which it's been implemented is quite tricky. And what you perceive as simple, actually, as soon as you're in the hospital, becomes complex. And so, the question, what do you think, and what needs to be done to improve this great gap in Africa? Well, we need to probably be focusing on quality improvement and implementation. And this is why the work of the N4PCc is so important. And I think their work has illustrated really nicely how, if you create a data network and you allow benchmarking, you can do a quality improvement, and you can do it locally at sites, and you can benchmark your own activities, and you can improve and provide better care. And at the moment, what we're looking towards is a large quality improvement project for Africa, if you're talking about these post-operative or perioperative surgical outcomes. So I think that as Maru, that's probably the main area at the moment. Turunesh, do you want to carry on with some of the questions? You are muted. If you want me to stop and you want to go to tea, just do this and we can stop.
No, the host is muting my mic, that's why. More questions. Question from Iheno is asking how to integrate the service, especially the research area on critical care, with your organization and to work with you.
Okay, so thank you for that question. I think that's a really important question. I think probably the three very important things have happened. The first is ACOS was the first time the APORG network worked with critical care as well. And I think that was an extremely important project. It grew the network and it grew the critical care arm of the network tremendously. The second thing is, I think, again, the work with N4PCc in Ethiopia and their critical care work is also consistent with that need to build the critical care component, and that is also how we ended up at this meeting, with a combined meeting with APORG and N4PCc. And then finally, we also have been working with a number of other critical care people across Africa within the APORG network, including people, for example, like Tim Baker and Arthur Quizera and others. So I believe the critical care aspect certainly is a focus as well now.
Thank you again. There is one more question out there. After ASOS and ASOS2, what are the next research priorities for the network or clinical trials in the pipeline?
Okay. So there are a lot of things going on simultaneously. So there's obviously the understanding the pediatric outcomes, that's ASOS speeds. In the background, trying to build this quality improvement project, probably starting at a pilot phase. So that's going on. You're going to hear tomorrow about the African Perioperative Network, which is basically how we keep all our clinician investigators together, informed, how we can make contact, how we can create groups, how we can do research projects together. So there's all that going on, and you'll see through that network, one can access the network. You can see all the projects that people are trying to work on, areas they're trying to develop. You can join them, you can show interest. So there's all that going on as well. And then there's this also commitment to this area of acute care in the perioperative and critical care space, which has also been developed.
Okay, we just had another question again. We're breaking for tea after this session.
Okay.
So answer all the questions and we go for a tea. It's a Siraj asked, I want to ask one concern, how the healthcare system implementation improved by the previous ASOS and ACOS trials. I mean, how the study contributes to the healthcare policy.
Thank you. So this is certainly an extremely important question, because it's pointless us doing all this work and it doesn't change healthcare policy, which is implemented and makes surgery and critical care safer. So I think the first thing we've done is we've created an awareness of the outcomes in Africa, and that's certainly important. That's important for advocacy. Despite the poor outcomes that have been demonstrated, and I'm going to discuss this, I'm not sure if it's today or tomorrow, but what we've seen is that people have really embraced the work. People haven't been critical of the outcomes. What they've been more engaged with is that we've had the ability to show what's happening, which means now we've got a target on what needs to be addressed. And ASOS2 was the first attempt at that. But once we start to show success, one would hope then that these successes will be translated to policy. And that's why, I mean, from my personal perspective, it is extremely exciting to have been able to work so long with Ethiopia and the Ministry of Health. They've been extremely proactive and interactive in all these projects. And I would imagine that they would be extremely positive about integrating into health policies once we show interventions which are benefit.
Any other question or comments, ideas before we break for the tea breaks? I can't see any hands raised. All right then. There is another question, so let's break for tea. We have 20 minutes, so we'll be back after 20 minutes, like about 10:40, just 10:40, because we have three
Thanks
other
very
minutes.
much.
Yeah. See you.
Thank you. Bye.
Bye. Welcome back, everyone. Now we'll proceed with Professor Rupert. Professor Rupert, as I've already introduced earlier, he was graduated in 1996 from St. George's Hospital Medical School, London, UK. After a time of working in general medicine and anesthesia, he returned to St. George Hospital, where he developed many of his current research interests and completed his training in intensive care medicine. 2006, he was appointed like a senior lecturer in intensive care medicine at Queen Mary University of London, and he was promoted to a professor. He has now given up on anesthesia to concentrate on his clinical duties on the adult critical care at the Royal London Hospital, and his research into improving patient outcomes following major surgery. Rupert has played a leading role in a number of large multi-center trials and has growing interest in global health research, including as chief investigator of a major global health trial of high versus low oxygen concentration in major abdominal surgeries. He will be speaking on what is global health, why is it important, and what percentage of it is an acute care. So for the next 30 minutes, we'll have a presentation, and then we have 10 minutes of discussion after that. So like we said, let's put our questions on the chat box, or we can raise directly on the screen as well by raising hands. Professor Rupert, you're welcome. Floor is yours.
Good morning. Sorry, just trying to mute myself there. And apologies for the slight confusion of not being able to get on. And thank you to Bruce for taking my slot so that I could still join you. A bit of a confusion at my end. It's all my fault, so I do beg your pardon. But I'm here now, and it's very, very kind of you to speak. Really, I see myself primarily as supporting others in global health research. And I feel very strongly that concepts of global health and the research we do and how that changes the healthcare that we deliver really has to be locally led. It has to be led from within the hospitals where it's happening, within the regions where it's happening, within the countries where it's happening. And there's lots of reasons for that. But probably the two really big reasons are that we are learning more and more and more just how important local context is, that my hospital may have differences to the hospital in London next door, or difference to hospitals in France, or difference to hospitals in Brazil. And we probably, as researchers, haven't understood how big that context is in terms of what we call applied research. Now, applied research is a kind of branch of research where we're actually looking at how healthcare systems work, rather than developing a new drug to treat maybe tuberculosis or HIV or pneumonia, or a new inotrope for patients who get hypotensive. You can do that research in pretty much any country, and it's still pretty much relevant to any country. Whereas applied research is very specific to the type of healthcare that you're operating within what type of hospital, what department, what country. And so context is tremendously important. And so leading the research with somebody who understands that context and leading the implementation of whatever we find in our research is really important for that local context. And so we need to find ways of helping people within countries to lead that work, but still making sure the quality, the standards, the rigor of that research is incredibly high. And of course, we know that type of research is extremely specialist, and it needs a lot of experience and expertise, specialist statisticians and economists and databases and people like me as well. So working out that collaboration, I think, is really important. I think the second reason why I feel very strongly that people like me shouldn't be at the front, but should be rather at the back supporting, is because whatever we find in our research and whatever we decide to do with those findings, whatever changes to the healthcare system, it needs to be sustainable. We need to improve things in a way that means that we don't come back next week, next month, or next year and find that that improvement was okay for a while, but we ran out of resources, we ran out of money, we ran out of staff, we ran out of equipment, or whatever it might be, and things went back to how they were. And again, you need people who understand the local context to help sustain improvements in healthcare. And you need people who understand what will and won't work in that context. Now, this may all seem sort of very specific to global health in low middle income countries, but we're actually finding very much this kind of logic in healthcare systems in high income countries. And I've done implementation research in high income countries, and it's very, very much the case that if we don't think about each individual hospital and each individual department and how that is different to other departments, that our interventions to try and improve things don't fit with the way they run their department. So it makes perfect sense that that same thing is going to happen in a global health context. And so it's very important that we are all engaging together on this, and that we encourage and support you within Ethiopia, but other colleagues in other countries within Africa to be leading that research and helping you to deliver it to the highest possible standard and disseminate it really well. But nevertheless, I'm really delighted to be asked to come along and speak, and I'll share what little I can to help you. So really, I've been asked to talk a bit about the concept of global health, how that relates to acute healthcare and how big a part of global health is acute healthcare. So, sorry, my keyboard is now misbehaving. So what is global health? Well, I guess it's what it says on the tin. It's considering healthcare not at a country level or a continental level, but thinking about healthcare concepts for the whole planet, for all of mankind. But I think in a UK context, the why the global health really is important is the notion of global health security. So I think for a lot of people, global health, well, it's not about the health of people in Europe or North America. It's about the health of people in low middle income countries, maybe in Africa, maybe in South America, maybe in South Asia, and so on. But actually, that's not what global health is. Global health is about everybody. And global health is a way of thinking about healthcare that promotes and helps people who live in high income countries and perhaps don't think much about the difference, that gap in healthcare between high income countries and low income countries, to understand why everybody's healthcare matters to everybody. So, and I'll talk a little bit about COVID in a minute, inevitably, but it's really about global health security. That if we can ensure that healthcare, for example, across all of Africa meets a good, solid minimum standard, then that's going to mean that African healthcare systems are more robust, and when big problems come along, are better able to cope. Now, certainly that's been a driver for a lot of investment from the UK government in global health research, much of which has generated funding which has come to African countries, amongst others. And I think, I hope that everyone in the UK realises that the pandemic has only reinforced the necessity for that kind of work. So this is where I work. This is the Royal London Hospital. It's in East London. If you've heard of Jack the Ripper and the Krays, who are famous villains of old London, they hung around in Whitechapel. So for the UK, it's a relatively low-income area with lots of social deprivation and quite a lot of high levels of disease in the local population, and a very diverse population, very multi-ethnic. So this is where we work. We're very lucky that our old hospital was replaced by this lovely big new blue box. Some people say it's quite ugly, but I don't really care because I'm inside it, not outside looking at it. So that's the hospital where I work, and you can see that it's placed on a junction between some of the wealthiest parts of the world. If you look down in the bottom left-hand corner of this map, this is the City of London. You can see the Tower of London here. This is Tower Bridge. This is where the London Mayor works down in the bottom right. And this is London's, this is just the edge of London's financial district. And you can see Canary Wharf, another financial district on the top right. So sandwiched between huge centers of wealth generation, global wealth generation, with these huge international banking empires. And there's a place where there's actually quite a large amount of social deprivation. And one of the funny things about the UK is how poverty can coexist alongside tremendous wealth in some areas. So, you know, understanding that local population, many of whom come from low-income countries to live in the UK, and their families are moving back and forwards between those countries. They maybe come to the UK in middle age in some cases. They don't speak English as a first language, perhaps they don't speak English as at all. They struggle to engage with healthcare. How do you register? In the UK, we have primary conditions, but how do you even register with one if you can't speak English? And what if you have an infectious disease and that's a problem for local healthcare in the local community? So our big local population from Bangladesh that live around the hospital where I work, their health in Bangladesh matters to the health of people in London, partly because they use a lot of our health resource quite appropriately, but you know, we need to think about, you know, how we can provide for them and make sure they have enough healthcare. And partly because some of the diseases they come with are infectious, and obviously we want to limit the spread of TB and other infectious diseases. So that's just one example of how, from a high-income country context, health is important. And I think for you listening today, the reason that's important is because this is how we get investment in research and improvement in healthcare systems in low and middle income countries. This is how we encourage people who live in wealthy countries to share some of their wealth in the investment in how do we develop sustainable, better healthcare systems in low and middle income countries, because it's good for everybody. And just to really hammer that home, this is where I've been for much of the last 2 years. We've been in a very well-resourced intensive care unit that the top floor of my hospital had some vacant space and was turned into a huge intensive care unit. And the photo on the bottom right is just 1/10 of the area. So we had nearly 200 patients on ventilators in our hospital in this massive area. And it looked like something almost out of a, you know, a film, a thriller of some description, with row after row after row of patients with COVID on the ventilator. And you know, everyone everywhere has had a horrible experience with COVID, but certainly we had a horrible experience with it in the UK. very high expectations of our society, but not always prepared to give us the resources we needed to deliver great healthcare. And COVID is the classic example of why we need global health security. Investing in global health is so terribly important for high-income countries. And this is important because it's an underpinning case for financial investment, both in research and in improving healthcare systems. So sorry to labor that, but I think it's a really important idea. And you know, that if you look, it goes beyond just people who have COVID. So this is surgical mortality in the UK over the period of the pandemic, some research done by one of my junior colleagues, Tom Abbott. And you can see that the green bars and the red bars. The red bars were patients who had COVID infection, and the green bars are people who didn't. But you can see that there is a very clear signal of excess deaths from surgery during the big COVID waves that we experienced in the UK. So, you know, these pandemics, they don't just result in people dying from the infectious disease itself, in this case, COVID. It rocks healthcare systems in every sense. And everybody's healthcare suffers. And this is what I'm telling people in the UK all the time, that the pandemic isn't just about people with COVID. It affects everybody's healthcare. Whether you have a road traffic collision and come into hospital with trauma, whether you need diabetes care, whether you're having surgery, your healthcare system is not as good in a pandemic. And that is a really big issue, certainly for the UK, but for all high-income countries. So if we then zoom and look at the pandemic in a global context, as I think people do, you can see, you know, well, this numbers are a tiny bit out of around at the moment, nearly 5.6 million people in the world have died from COVID. 5.6 million people. And without being political about it, when we think about how much money we invested in the response to, for example, the 7/7 incident in New York, and the number of people who died in that incident, and then we come and we find something where 5.5 million people have died, you know, are we investing the same amount of global resource in the problem? I suspect that it's not even close. So this is the map from the World Health Organization on the presence of COVID around the globe at any one time. And I just want to highlight, you can see here in Africa that the colors are quite lighter. Now, we don't know whether that's accurate because this is based on reporting of data, and most countries have based their reporting of data on their ability to test patients to confirm that they have COVID. And if you don't really have the healthcare infrastructure to diagnose people with COVID, to treat people with COVID, you're not going to register COVID cases, and you're going to under-measure, under-record the incidence of COVID disease in your country. And I've been watching this map change colours over the last couple of years, and I continually wonder how big an issue COVID is in Africa as an acute disease. And, you know, it may be because, you know, a lot of countries which are generally have a colder weather system than a lot of African countries, maybe COVID as an infectious disease is less prevalent in Africa. Perhaps, I don't know. It doesn't seem very likely that it would be that much less prevalent. It's much more likely that COVID is incredibly common in Africa, but we don't have the systems to measure it. And so we think that it's not a big deal. Whereas what's much more likely is that people are quietly dying of COVID and nobody notices it because we're used to those healthcare systems being under-resourced and not being able to deliver the care that everybody needs. And I don't think that's okay. You know, why should people in one country have amazing healthcare and people in another country have no healthcare at all? And this is one thing where, you know, in the UK we can relate to, because, you know, if you go to the United States of America, they're very proud of the fact in some cases that they've got the best hospital in America. So one of my colleagues works in New York, and the website for his hospital says that his hospital is in the top 5 best hospitals in the United States. And they're proud of that. But the thing is that if you've got a hospital in the top 5, you've also got a hospital in the bottom 5 somewhere else. So if healthcare is amazing in one place, it's also rubbish somewhere else. And in the UK, we have a national healthcare system, NHS we call it. And in the UK, if somebody in one hospital has worse care than somebody in another hospital, it's considered socially unacceptable. It's not okay for people, say, in Manchester, in north of England, to have worse healthcare than people in London, in the south of England. And that will be brought up in the media, in the newspapers and on television, and people will be arguing that it's not acceptable to have differences in quality of healthcare across the United Kingdom. And that's conceptually very different to the United States, where they're quite proud of those differences. And I've never quite understood it. But to me, you know, if we understand the importance of having great healthcare across the UK, then why don't we understand the importance of having great healthcare across the whole of the globe? And I think part of that is because we don't understand how important it is for all of us that healthcare across Africa is really good. And, you know, there are relatively inexpensive changes that we can make to healthcare systems that could improve that. I think probably the most complicated thing to resolve is around staffing, but you know, with the right kind of sustainable investment, these are solvable problems. And we just need to recognize in high-income countries our responsibility to the whole of the planet to support that. And I think that's a really important issue. So what are the global health concepts for acute care? Well, I mean, this is no surprise to you. I mean, obviously, surgery is a big topic. Trauma is a big topic. Sepsis is really a funny word. It really defines something that people invented so they could do research. It's not actually a real thing most of the time. I prefer the term infection. Infection is a group of diseases that can make you critically ill. But I think sepsis is a very recognizable term, but it's a very misunderstood term. I also think that we need to think in the context of a healthcare system, critical care, because critical care is something that crops up all over the place for all sorts of different diseases. And in a system level, it's a bit of a safety net that's very important. And then finally, emergency medicine really, again, sort of overlaps with critical care, but it's a safety net for all the diseases that we see in acute care. And so sometimes it's important to think about the patient problem as the disease that the patient has, but sometimes it's quite important to think about it at a healthcare system level, label that by, you know, the care that we give or the job that we do, and developing it in that way. So I think those are some of the, really, for acute care, some of the most important problems. And of course, global health for so long has been heavily centered on chronic diseases or long-term diseases. So, you know, HIV and TB and malaria are, of course, tremendously important problems. And it's absolutely right that we invest in prevention and treatment of those kinds of diseases. But I think there's been much less recognition of how damaging acute care can be. And I think that there's also not the recognition that acute illness has a high chance of translating into long-term illness. So if you have trauma and you have a spinal injury, you have a long-term problem that you won't fully recover from. You know, and there's all sorts of long-term impacts of these acute harms that add to the burden of long-term disease for those people that suffer from them. So seeing acute healthcare as a driver of long-term illness, both for the individual, but also healthcare systems that have to support those individuals, but also the economy, their family, the risk of catastrophic expenditure in an acute sense for people who have to pay for healthcare for somebody, but then they're left with somebody who needs aftercare and there's no healthcare system to provide that, and the family have to provide that. And so acute healthcare is a really important driver of poverty, and better acute healthcare is going to be something that really improves quality of life in all countries. And so it's been quite neglected in the past, and it's good to see that we're starting to focus on it more. So this is one early attempt from our group to drive an understanding of surgical care at a global level. Whilst I'm quite proud of this study looking at surgical outcomes, you can see that it's obvious that there's a lot more to do in terms of our failure to be able to support and include African nations in that kind of research. Fortunately, Bruce and colleagues were able to resolve that with a follow-up study using the same model, this idea of a 7-day cohort study that didn't use too much resources to deliver the research. And ASOS really is a game changer for healthcare in all middle-income countries, in my view, but obviously in particular Africa, by defining the fact that as a general rule, people having surgery in Africa were younger and were lower risk, but were twice as likely to die after surgery than those people in high-income countries and compared to the global average. And as we seek to improve access to surgical healthcare for all, we can expect that if we don't improve the quality of perioperative care at the same time, that we'll see a lot more deaths after surgery. So there's no point improving access to surgery if that surgery is not accompanied by good quality perioperative care, because if a patient has a complication after surgery, that can completely negate the benefits of that surgical treatment. So it's really important that it's not just surgery, it's safe, good quality surgery with safe, good quality perioperative care. And I think ASOS really helped us to realize how important that is, and it's really helping us to make the case for better perioperative care. And so just the general concept of safe surgery, the fact that there's not the resources we need at the moment available to deliver that in the way we'd like to. I think that the very high burden of untreated long-term disease is a key driver for poor outcomes, and something that we need to understand of how we support how does acute healthcare support the treatment of long-term disease. Now that's a big challenge, but when a patient with a long-term disease comes into contact with a hospital for an acute illness, what are we doing to treat their long-term illnesses as well? Can we solve that problem? And I think we can. It's very complicated and difficult to do, but it's an opportunity we need to find and take. Do we properly understand the geographical factors and how they vary from hospital to hospital, region to region, country to country? And sort of understanding not only the issues of access to surgery, but access to good quality surgery. So in a surgical sense, there's a lot there still to do to improve the access to good quality care. Then there's the notion of critical care and what the minimum standard of critical care is. And on the top right, this is a COVID intensive care bed in the hospital where I work. And at the bottom left, this is the high dependency unit at Mbali Regional Referral Centre Hospital, where some of my Uganda research collaborators work. And you can see the difference in technology. I mean, just looking at the technology of the bed itself that the patient is in, you're talking about completely different systems. And my fear for critical care, it's incredibly staff expensive, it's incredibly resource expensive, and it's incredibly financially expensive. And there's a real risk that rolling out critical care for low and middle income countries could turn into a kind of a vanity project where we have a shiny building or a shiny facility, but it doesn't have the capacity to really transform health and well-being for large populations. And so we're really stuck there because we know critical care is really important as a concept for all acute healthcare, but we also know it can turn into something that's incredibly expensive very, very quickly. So how do we focus around the low-tech solutions to critical care needs? How do we deliver teachable skills? And how do we see critical care as not being about a geographical place in the hospital? It's not about real estate, but as a concept, as a set of skills that all our healthcare providers have. And so that's the big challenge around critical care. And I think that there are some groups making some excellent progress with this. Arthur Kwizera in Uganda, Tim Baker leading some work from Tanzania with colleagues. So we are making really good progress with this. In his talk about failure to rescue. Failure to rescue is when a patient dies after surgery from a complication. And if you're having elective surgery, you would expect the overwhelming majority of people who have elective surgery to survive. Could argue that nobody should really die after elective surgery. Now, about 25, 30 years ago, there was a recognition in high-income countries that a lot of people did die after surgery. And when you went to the patient to look at what happened, the nurses were taking blood pressures and pulse rates and respiratory rates and writing them on the chart and not telling anybody. And you could see the pulse rate going up and up and up and the blood pressure going down and down as the patient bled out. And then they would have a cardiac arrest, and then people would come to help them. But nobody contacted a doctor before then and said, this patient is sick, come and see them, so that someone came along and diagnosed the bleeding before the patient had a cardiac arrest and prevented failure to rescue. So seeing a postoperative complication as an opportunity to stop a patient from dying. And to do that, we need something called capacity to rescue. And that means that we need both the resources and the training to identify people who are deteriorating after surgery due to complications and to intervene and do something about that. And so the concept of failure to rescue, I think ASOS showed us, is a huge driver of death after surgery in low and middle income countries, and it's been a major target for the research that Bruce has been leading in the APORG group. And one of the other big categories that I would focus on is maternal hemorrhage. And I think one of the reasons that maternal hemorrhage is really important is firstly because we are talking about often young, healthy women who are dying, who are creating poverty because there are children who aren't supported and don't have a mother to care for them. There are whole families who are facing catastrophic expenditure as a result of the death of a mother. But most of all, because it does look very much like we have a whole raft of interventions to prevent and treat maternal hemorrhage that we're not properly using. So this is a really great example of applied research, implementation science. We know what we can do, but for some reason it isn't happening all the time for every patient. And because it isn't happening all the time for every patient, a woman in Uganda, like this lady here, might die from maternal hemorrhage, whereas in the UK, it would be considered a catastrophe. And in the UK, death in childbirth is a huge, is a huge thing. It will be in the national media, and regular reports of deaths in childbirth are reported in the national media. The expectation is that it should not happen. A woman should not die in labour. Now, if we think that about people in the UK, then why don't we think about that for people everywhere? And I think I can't see a reason why we wouldn't think about it that way. So, you know, I think maternal hemorrhage is a terribly important area where we need to simply start by using the knowledge we have. But to do that, we have to do something called implementation science, where we understand what is it that's stopping us using that treatment. And it's sure it's not because we don't care, because everybody cares. Are there reasons why those treatments aren't being used? Is it because we aren't properly trained? Is it because the tranexamic acid is in a cupboard on the other side of the hospital and we don't know where it is? What are the reasons? Because we've learned in high-income countries that those kinds of reasons are actually big drivers for problems in healthcare delivery. And so through people like me, we can use the research learning from research that's done in high-income countries, apply the same concepts in low-income countries very effectively, because it's the same kind of research and it's the same kind of skill set to delivery. And that's what I hope that I am able to provide to the African Perioperative Research Group. And then a quick mention about humanitarian aid. This isn't quite the same as global health that we've been talking about thus far, but you know, there are lots of refugee centres across the globe, often in war zones, where there are humanitarian hospitals led by the Red Cross, the Red Crescent, Médecins Sans Frontières, and so on, providing emergency care and starting to think about humanitarian aid as a healthcare system in itself that needs improving as well. And so we're starting to do research with groups from these various charities to see what we can and should do to improve healthcare in that context as well. So this leaves us to different research themes. We need to do epidemiology to understand our populations and to count people across the whole populations. We need to do something called mixed methods research, where we don't just count numbers, but we actually go and talk to people. We interview people. Why couldn't you give tranexamic acid to that patient who was bleeding? What happened? You know, that kind of research. Or maybe watching people at work, that's called ethnography, what people, you know, speaking to them in their own environment. Something called complex interventions, and complex interventions are what we need to do to deliver these improved standards of care. So if you want to understand a complex intervention, there's a great analogy that one of my colleagues uses. So if we think about a pen like that, now that's a simple device, a simple technology. It's got no moving parts. I can take it apart very quickly and put it back together again, and there's not really that much to it. If you think about complicated intervention, that might be something like a racing car or a space rocket. It's got lots and lots of bits to it, but there's a design, there's a diagram that shows you how they all fit together, and you know, you can take it apart and put it back together again, and it will work in exactly the same way as long as you follow that design. A complex intervention is a bit like a teenager. You know, you can parent your teenage child and teenage children in exactly the same way and get a very different outcome every time you do that, because they don't respond in the same way every time. And complex interventions are designed for that third category, that if you do the same thing everywhere in every hospital every time, it doesn't necessarily work in the same way. So we need to understand that local context, and that's where the mixed methods research comes in, the epidemiology comes in, helps us understand the differences between hospitals, helps us design interventions with staff and patients who are based in those hospitals to design interventions that work in every context. And that's really, really important. Then we need to do things called cluster trials, which are the best design of trial to study complex interventions. And then perhaps in the future, we'll be designing new treatments that allow us to improve patient care. And through those, we'll do those more simple individual patient randomized controlled trials. And this is one example of an individual patient RCT that we're doing. This is called Penguin. Quite a few African countries are participating. South Africa is taking part. Ghana is taking part. Nigeria is taking part. We look forward, hopefully, to Rwanda and Uganda taking part as well. So, this is quite an important opportunity to study. We're studying chlorhexidine mouthwash to prevent pneumonia, and we're studying oxygen therapy as a prevention for surgical site infection. And it's a good example. Oxygen therapy is a resource-intensive intervention for many hospitals. If it works and prevents surgical site infection, we need to invest in the infrastructure to use it, because surgical site infections are a big problem. But if it doesn't work, it doesn't prevent surgical site infection, we need to not do it. We need the World Health Organization not to recommend everybody does it, because it uses up resources that we need for other patients. So a really good example of how global health research relevant to low and middle income countries, that takes place in low and middle income countries, can allow you to understand whether resource expensive interventions are worth the money, the staff, and the facilities that they use. So one final plug, this is a study in South America, in Latin America. It's LASOS, so we're just about to launch an equivalent study to the ISOS and ASOS studies that have been done before. And just realizing that actually, if you're in a low-income country and you're trying to improve your healthcare system, what you're probably doing is increasing your capacity of your healthcare system, increasing the volume of patients that you treat. When you reach that stage, you'll find that you've got a whole load of different challenges about improving the quality of healthcare. And as there are different countries at different stages of that pathway around the globe, we can anticipate that, for example, challenges that Brazil has as a middle-income country in delivering great healthcare will be challenges that, for example, Uganda can expect to have as the healthcare system there improves. So sharing learning, not just between high-income countries and low and middle-income countries, but between low and middle-income countries within the global south, is an incredibly valuable approach. And that's something that we really want to see more of, is how low and middle-income countries share concepts and understandings between them to make the most resource-effective way of improving healthcare. Finally, plug for the African Perioperative Research Group that Bruce and colleagues set up, that's now really, I think, the envy of global health researchers around the world. It's been incredibly successful. And what Africa has achieved in perioperative care research with virtually no resource whatsoever is humbling. There's been a huge success. All credit to Bruce for being an amazing leader of it. I know Bruce will say that there are many other people who have helped, and of course there are all over Africa. People have been making absolutely superb contributions. And I just want to say that APORG is going to make a huge difference to the quality of patient care in Africa as the group starts to deliver research that really defines better ways of delivering healthcare. The research to date has really strongly made the case for the importance of research on these kinds of problems in Africa. And I can now announce formally that Ethiopia is one of 4 countries in a major global health research grant that we've just secured for research in Africa. And so Ethiopia, Uganda, Tanzania, and South Africa are the 4 participating countries, and we'll be delivering a series of large projects through APORG. And it's absolutely amazing that Ethiopia is going to be one of the key countries within that. And we're really grateful to FITSUM and everybody who's helped support us putting that grant application together, which has allowed us to channel resources from the UK to Africa. And over 80% of the funds in that project grant will be spent within Africa. And so that's a really great success, and we hope to see more of these successes. And I see my job really was helping that finance to reach you, and being a channel for that, and to be giving advice and support for research and implementation science that you all deliver in your own local contexts. So next steps, yep, we've got a lot of work to do to set up our NIHR Global Health Group. We've got some large, simple clinical trials to deliver. We need to still work hard to understand every hospital's healthcare context, and we need mixed methods research to do that. The APORG group is about to shift into a whole new phase, delivering applied health research, and is now in a position of having a very significant amount of funding to deliver that high quality research. So that's excellent news. And we need to start building links with other groups, such as the Global Surge Group that's seeking to improve surgical care, but other groups as well in critical care, in global health for maternal care, and so on. So we're making excellent progress in acute healthcare, but we've still got a long way to go. And I think I probably talked for long enough now. I'll be happy to take any questions. Thank you.
Okay, thank you for that inspiring presentation. Now let's go for questions or opinions. I can't see any question on the chat box. Anybody? You can raise hands.
Can I just thank Rupert for all the support he's given us. He's shared selflessly, basically study methodology, mentorship, etc. And I don't think we would be here without his support and his mentorship. So thank you, Rupert. It's really appreciated.
Yeah.
Okay, some questions on COVID-19. Would you like me to answer them, Trinesh?
Yes, please go ahead on that.
Yeah, so a question in the chat highlighting the huge impact COVID-19 has had, and just asking some questions about that. So what special considerations need to be taken for people who will be undergoing major surgery, and what makes them vulnerable? So that, I mean, that's a really good question. The problem is that infection and prevention control within hospitals is incredibly resource expensive. It's expensive in terms of geographical resources, because you need to have wards and theatres that run what we call green. So in my hospital, we have a green pathway for people who've been shown to not have COVID, and only cared for alongside other people who don't have COVID by staff who've been shown regularly to not have COVID. We've got the people who definitely got COVID, and they're in obviously separate wards as well. And then there are people we call amber, and that's the people we don't know. Maybe they do have COVID, maybe they don't. And so you've got one hospital that suddenly has to divide into 3 hospitals. That's incredibly resource expensive. And of course, it doesn't work perfectly. You still see some people having COVID. So I think it's really, really difficult if you're running a hospital with surgical services, because you're going to, if you take extreme measures to prevent patients from getting COVID from after surgery, you will probably find that you are offering less surgical treatment to your patients. And in some cases, that may cause fatalities in itself. And I think it's a really, really impossible problem to square as to how we do this, because the pathways to keep people COVID free around surgery are incredibly expensive. They involve people isolating before surgery for several days. So people have to be able to afford to stay at home and not go out. And obviously people who work often can't afford to do that. They need to be regularly tested for COVID to prove they don't have it. And that can be difficult resource-wise, and getting both the testing, but getting the tests to the patient while they're isolating. And then of course you need these separate environments where people don't mix with people who do have COVID. And all of that is very, very demanding. So to be honest with you, I don't think there is a good solution for resource-poor hospitals in low or middle-income countries at the moment for delivering surgery safely within the pandemic. And I think that is one of the drivers that's going to keep the pandemic going. And until people in high-income countries realise that they're not safe until everybody's safe, I think that this problem is going to continue. So I know what the answers are in a very resource-rich context, but I just don't see how they're practical in countries where vast amounts of resource aren't thrown at the problem. Even in the UK, we are desperately short of staff at the moment to meet the healthcare goals that we've set for ourselves. What do you think needs to be done to reverse back to the catastrophic effect of COVID on acute healthcare, including surgery? So that's a difficult one. I mean, in the UK, we know a huge amount of people have not had surgery during the pandemic who would have had surgery, but they've sort of disappeared and we don't know why. Did they simply die at home of a perforated appendix? Or did they decide that they didn't need their hip surgery after all because their hip didn't hurt that bad and actually they're fine? A lot of these patients who would have had surgery have disappeared. And I do have a growing theory that in the UK that there may be a curve of the benefits of doing more surgery versus the amount of operations that we do on people, and that we may be close to the point where actually doing more surgery doesn't bring more benefit to our population, that it may even make our population less healthy overall if we keep doing more surgery, because you have more people who are high risk, older, have lots of chronic diseases and so on, having complications and then having a poor surgical outcome. So that, if you think about it, is the UK context. How that maps out in lower middle income countries, I think we're very, very unclear about that. But I would personally argue that it's the same challenge we've always had for surgery in lower middle income countries, and that's that we need more access. We need the scale of surgery to be increased quite substantially, and we need people to be able to access that surgery, and that surgery needs to be of good quality and safe. It doesn't need to necessarily be the kind of surgery you get in Mount Sinai in New York, or in the Massachusetts General Hospital in the United States, but it does in Boston. It does need to be achieving a good minimum standard, and I think that goes for all acute healthcare. So I would probably argue the challenge we've got there post-COVID is the same challenge we've always had, but hopefully we can use the pandemic to highlight that need. And I certainly think that organisations such as the Wellcome Trust have become much more aware of the need for critical care in Africa than they were before. And then number three, the challenge for emergency medicine, the lack of essential life-saving drugs. I agree. As an expert, what alternative mechanisms the healthcare system should consider to counter this? So what I think the most important thing for emergency medicine is at the moment is the staff with the right training. I think that drugs are important, and I think equipment is important, but unless we have a small army of well-trained staff who are still present, who we are not losing to the well-resourced hospitals in the big cities, or who we are not losing to other countries, be they middle income or high income countries, then we're never going to solve the problem of emergency medicine or of critical care. And we've got to find a way of solving that problem. And I think ultimately it will be around how we make sure that trained healthcare staff are properly paid. And so that we reduce the problem of out-of-pocket expenses in acute healthcare, which is a big problem, and take it from there. So I think that I would start with the people rather than the drugs or the equipment, because it doesn't matter how many drugs you've got, if there's nobody there trained to use them, they aren't going to solve our problem. I'm just going to skip down because I think there are some more questions from Salome. Oh, thanks, Salome. That's very kind of you. Everybody's health matters. Ethnography deep dive research zones. May then be difficult to report, publish when they highlight local care issues. Well, so someone's highlighting that if you do local research in a local hospital, it may be hard to get it published. I think we need to fight against that. I think we need to prove to people the research we're doing is important and force them to publish it. And 20 years ago, when I started studying surgery in high-income countries, nobody thought it was important. Nobody cared about it. So we went off and did big epidemiology studies to prove that it's important. And now people do study it and they do fund it. And I think ASOS has had that impact for Africa. Hi, Lou, I see you've got your hand up.
Thank you, Professor, for an excellent presentation. I do have just one question. So you raised the issue of the evidence generation challenge that existed, especially the difference between global south and global north. And most of the evidence generation have been kind of derived from global north, the rich countries, especially when it comes to funding, like low middle income country researchers are so affected in that. And I'm just wondering, with your experience, you have been involving in a lots of low middle income research, and what strategy do you suggest for researchers from low middle income country, institutions from low middle income country to penetrate this really difficult and historic? It has been there, like with global health history. And yeah, any suggestion you do have around that? Thank you.
I mean, it's obviously a big challenge, and you will find researchers everywhere complaining that they don't have enough money. So that's a normal thing. I think that there are two big things that I would try and do. The first thing is to ask for what you need. So if you need access to statistics software, don't ask for money to buy it. Ask somebody to give you access to statistics software. If you need to go on a course, don't ask for money to go on the course. Ask for someone to let you go for free. And so on. If we need people to do PhDs, don't ask for the PhD fees. Tell the university, give me the place on this PhD course for free. By asking for resource, not for money, it's often much easier both for individuals and for organizations to give us the things that we need. But if you ask them for money, they may not have any spare money to give. And so the first thing is really think about, what do I actually need here? Is it money or is it a thing? Because somebody may be able to give you that thing much more easily than they can give you the money to buy it. And I think that's really important, because in research, as much as 75% of the resources you need can be given rather than bought, depending on the type of research it is. I think the second thing is that research everywhere needs buddies. It's collaborative. We need people to join together and give each other a leg up. And so I would encourage people to network through APORG, and that we use APORG more to bring in people who've been able to deliver research successfully. at scale, and come in and help show how that's done, and also to play the role of a conduit for funding, and to help you access the funding you need, to be that, in some places, quality assurance by being a guarantor that the research is high quality and well led, by putting their reputation on the line to support you. That doesn't stop people within Africa designing the research, leading the research and implementing the research. It is just somebody in the background going, these guys are good guys, they're doing great work, and we should fund them. And I will take responsibility for making sure that happens. That gives big funders that confidence to invest. And so I think more people need to stand up and be counted in that way. There's a very good question from Tim Baker about critical care and picking up on the issues of vanity projects. To be honest, do I have time to briefly answer that?
Okay, then just respond to that question and then we will move on to the next session.
Sure, I've talked for too long, I realize, I'm sorry. So Tim just highlights, how do we get health policy makers to focus on, often quite unglamorous, low-tech interventions as opposed to big, exciting, shiny buildings and vanity projects. I think that we need to think about health policy makers, be whether they're politicians or local hospital managers or whatever they are. We need to try and think in their shoes. How are they trying to show people that they're doing a good job, and try and understand them better and understand what their drivers are, and then try and make the thing we know people need look like the thing that they want. How can we make, resource inexpensive critical care, low-tech critical care, look like a shiny building that they can announce as a success to their people who vote for them or whoever it might be. I think we really need to think about that, what the policymakers need from us, not just to implement, but to actually allow them to be successful. Because if they are getting something from us that helps them, then they're going to want to work with us. They're going to want to use our research, and they're going to want to implement it, because it's a driver for them to be able to show that they're doing their job well. And we all need to show that we're doing our jobs well. It's important for all of us. And if we think of policymakers as people who have needs as well, and we think about what those needs are, I think we've got a much better chance.
Great, thank you for that. We will probably get answers to those questions on the chat box as well with Professor Rupert. Now let me invite Professor Catherine. Professor
Good
Catherine.
morning.
Yeah.
Can you hear me?
Yes.
Yeah, I just want to say thank you so much for APORG and our Ethiopian colleagues for the opportunity to speak this morning. I was just wondering if you could make me a co-host so I could share my slides. Sorry, Tiranesh, can you hear me?
Sorry, what did you say? Excuse me.
Is it possible to make me a co-host so I can share my slides? I'm unable to share my slides.
Yes, I guess. They're working on that.
Okay. So maybe I'll just introduce myself briefly while we're waiting. My name is Catherine Chu, and I'm a surgeon, and I'm the director of the Center for Global Surgery here in South Africa at Stellenbosch University. The topic that I'm going to speak on is about Africa and global health research. And I'm going to take a step back from that amazing talk by Rupert Pierce and talk about research in global health and African scientists in general. I would like to say that if all high-income research relationships were like the ones that have been established with Rupert, then I wouldn't really need to give this talk. But unfortunately, at least in my experience, they aren't all like that. And so that is sort of the basis for some of my talk. Where can I start sharing? I see that I'm a co-host, but I was wondering if you could help me out by telling me where it is that I need to go to share. Oh, never mind, I got it. Okay. Okay, so again, the topic of my talk is Africa in the context of global health research. So first, to put it into perspective, so Africa, we have 15% of the world's population, but we have a much higher global burden of disease, non-communicable diseases being a significant part of that, with many surgical conditions following into that, and acute care conditions as well. But unfortunately for us, we produce less than 1% of the biomedical publications worldwide. And somebody once told me that there are 4 characteristics of effective research. The first is individual research skills and ability. The second, and this is really important, is appropriate infrastructure. So here in Africa, those of us that work at universities don't always have the administrative or financial support to set up a research team or a lab. We don't have the statistical backup, and we don't have grant writers that can help us apply for money. The next important is to be relevant to national policies. And then lastly, effective research needs to be able to contribute to the global research and policy needs, which obviously, as Rupert had discussed in global health, to research health conditions that affect people in different countries. So the real question for the talk today is, how do African scientists become effective global health researchers? So the first thing to discuss is the Global South, Global North research collaborations, because I think that this can be a real benefit to those of us in the Global South, but it also sometimes, if not done well, can also be a real hindrance. So just to recap, global health is the practice of improving equity in health and well-being worldwide. And global health research is the study of how best to achieve this. And historically, global health research has been dominated by the global north, even on topics about Africa. So a recent paper published by Lee Wallace and his group about the COVID pandemic showed that 1 in 5 African COVID papers had no African authors. And more than half of the authors on these papers about Africa were not from Africa. So some of the extractive research pitfalls that some high-income research, again, not all, can fall into working on the African continent. And I don't know if any of you colleagues that are listening to this talk have ever had this experience, but I certainly have. So the first would be the taking of data without local permission, ownership, or capacity building. An example of that would be a surgical registrar, anesthesia registrar coming to rotate one of our hospitals but it certainly has happened in the past. The second one would be slightly more egregious, and that would be the taking of human tissues without local permission or ownership. And sometimes that's called mosquitoes research, where they come in, steal some of the blood samples, not steal, but take the blood samples, and again, do data analysis, basic science analyses on those specimens without any local permission, ownership, or capacity building of the local research team, if there is even one. The next point is that extractive research, if not done collaboratively, could not be locally relevant or appropriate. And Rupert touched on this a bit, but really only the local clinical teams on the ground know what is relevant. So, for example, sometimes there would be drug trials conducted in low and middle income countries here in Africa, but not necessarily that relevant for our context. This can result also, these type of extractive research, in no local authorship, no local dissemination. So the papers, the results could be published in very high impact international journals, but not always read by local clinicians or policymakers. And so did the results make any difference to the study population at all. And finally, and I think this is probably the most difficult, but probably the most important to discuss, is that was there any real local research capacity building? So for sure, in some relationships that are not equal, there is what I call token authorship. So the external team comes in, they do make some local collaborators authors, but was there any capacity building imparted during that relationship? And I hope that relationships like the one that Rupert has described will now get away from that. But in the past, I think there have been relationships like that. So the two problem statements, I think, are research relationships between Africans and high-income researchers are not always equitable. And currently, African researchers are not leading global health efforts, even on conditions that predominantly rise from our continent. So how can we change that? Well, first, let's address equitable global health research collaborations. And again, that's sort of what I'm talking about is between global North collaborators and global South collaborators. Again, let me highlight the positives of collaborating with folks in the global North, like Rupert. Or sorry, Rupert, because you went ahead of me. I'm going to keep using you as a positive example. So global health researchers have been doing this for a long time. They have at their disposal quite a lot of resources, both financial, but also knowledge, statistics, methodology, research design. And many of the research topics in global health, and particularly in acute care, have been researched in their countries and can be relevant to our context. So we certainly are not saying, or I'm certainly not saying, shy away from research collaborations with the global North. They have a lot to offer. But I think the questions are, how can African institutions and physicians benefit from international research collaborations without being exploited? How can advancement of African research capacity and academic careers be prioritized while still satisfying the publish or perish mandate of high-income universities? And I think that second part is something that we must acknowledge because I think it could be the elephant in the room. High-income researchers also have targets that they need to meet in their own countries, and that is also grant acquisitions as well as authorship on papers. And so we must feel that these collaborations are a win-win for both sides. And then finally, how do African scientists and governments coordinate the great influx of high-income academics who view the continent as the next frontier in global health research? So in some of the contexts in which I've worked, certain countries are sort of becoming very popular as the study populations for global health researchers. And sometimes the teams on the ground can feel overwhelmed, but also feel very complimentary that so many groups from high-income countries want to work with them. But how they navigate and coordinate and try not to offend the different groups that are coming can be challenging, especially if there's some overlap in the topics that are being researched. So sometimes, they want to say yes to very prestigious University A, but University B, also very prestigious, has also come in wanting to do the same research, but you don't feel like you have the power to say, okay, well, we've already working with this group, how can we all work together? So I think there are 7 different areas that I think could really help in trying to make these relationships equitable. The first would be to really focus on building local capacity, but using the high-income resources and the regional resources that could be offered at your disposal if you do have a high-income collaborator. So the first would be access to distant learning resources such as online libraries, courses on protocol development, statistical courses, data development and management. I think Rupert mentioned if these are being written into a grant to specifically ask for these courses for free as opposed to the money to take them, and I fully agree with that. The second is Hinari. I think hopefully most of our Ethiopian colleagues know about Hinari, which has really opened up access to journals. I think if we don't read about your topic, it's very difficult to become an expert in that field. And then finally, there are multiple South-to-South training opportunities. Groups like APORG now setting up so much research capacity here in South Africa and working with different research groups now all over the continent. I think Bruce has done an amazing job setting that up. There are universities Here in South Africa, I'll give an example. I know Salome Masimwe at UCT, they have lots of training courses being offered. At Stellenbosch, there's also courses on clinical epidemiology, health policy and management. And some of these courses could be much more affordable for African colleagues than going to a high income country. Setting the local research agenda, and I think this is really important. And I think Rupert also highlighted this, and having the local teams really drive the agenda setting. And I think only the team on the ground can know what is relevant to them. And I think that that is really important. Local research committees can be set up to do this, certainly understanding the local priorities. I think in the past, and hopefully it's changing, but a high income researcher will come into your area, for example, interested in diabetes. Now, diabetes happens to be a major health priority in South Africa, but it may not be in every context. And so they bring in their research priorities, but it'll be really important to set up local priorities. And I think for me, I also think that discussing with the local communities what their priorities are, so not just the clinicians, but the study population as well, the potential study populations would also be quite important in local priority setting. And I think this type of community engagement is being pushed much more by funders as well. And then finally, setting a local research agenda, but discussing that and then eventually dissemination to the local and regional ministries of health is very important. And then just to mention, of course, Global North partners can certainly participate in this, but I think this process should be led by the local partners. So long-term collaborations. And so there are many examples of very successful, equitable, high-income, low-income research collaborations. And I think Rupert and Bruce have one of them. But I certainly think that long-term collaborations build trust, and they take a while to set up. But just to say, they all start from somewhere. And so sometimes they start from personal relationships just between two researchers or clinicians, and eventually can build to very large formal partnerships. So two examples, not necessarily in acute care or surgery, are one from Uganda, the Rakai Health Sciences Program. This started with just two researchers, one from the US and two clinicians from Uganda working together. And they initially started on a very small community kind of cohort study. And eventually this became much bigger to clinical trials about community participation in studies. And now they've really established a multi-million-dollar research partnership. Similarly, and some of you have heard of KEMRI in Kenya. This was set up between a Canadian and a Kenyan researcher initially. They do a lot of malaria and HIV work, also now receives a lot of funding and has trained many researchers now from LMICs. And then the last thing to mention is twinning now. So twinning is sort of a new model that I think can have a lot of potential in research collaborations, where typically it's the high income country university that initiates an effort to link up with an LMIC university, again, sometimes starting from a personal relationship. But I think that then if the two universities have sort of a formal agreement of how that partnership will work, and that has a trickle down effect into individual collaborators. Often built into these twinning MOUs is the need and the prerequisite that trainees from the LMIC also are able to go to the high income country for formal degrees and courses. Because I think in the past, a lot of it was a bit one way. High income researchers and their students could come to the LMIC to do their projects, but there wasn't much traffic going the other way. So I think sometimes built into these twinning relationships is that. Local coordination and monitoring, again, when I mentioned about the research duplication, some study areas are very popular for competing Global North researchers, but a local team could coordinate this. Rwanda does an excellent job of monitoring all studies or all potential studies coming into their country. They have a medical board that looks at all that, and they always ensure that the studies are in line with preset local policies and priorities. To tag onto that, having a local IRBs. Again, this really looks into our local vulnerable populations and prevents exploitation. Again, some of these ethics and vulnerabilities may not be known by researchers from high income countries because they don't know the local context. And for sure, it can control the material transfer of the human tissue. So here in Africa now, we are able often now to do our own genomics, as during the COVID pandemic, we see that in South Africa, found the Omicron first. So human tissue doesn't always have to be sent out now. And I think that trying to keep some of the data and tissue analysis here on the continent also builds our own capacity as well. And then finally, to talk about the local authorship. So I think it's really important in equitable collaborations that the African co-investigators get involved in every step of the research and not just the final paper. I think that that is really important. And I think that's the dynamic balance that's sometimes a bit challenging because it takes time and it takes, well, I think it takes money, although Rupert says it just takes trying to get people on courses, but it takes effort if you have a collaboration between high income and low middle income universities to make sure all the African investigators have the ability to participate in all these steps. Because I think there's often a desire to participate, but there isn't the knowledge of how to do so. Hopefully that'll mitigate the extractive research. And then the really important part is that the local authors get a chance to disseminate the results in their own backyard and also to present at conferences. So in the past, because funding to attend international conferences could be an issue for those of us in Africa, attending local conferences was a great way to present the results locally and regionally. Although now I would like to say with Zoom, a meeting like this, African participants can also present on the international podium. And I think that is also real important for equity. So I got a recent publication, and this was termed African-led health research and capacity building, sort of the 7 criteria that they felt were important to build African research and leadership. And the first was to identify trainees. So it's really important to train a cohort of African research scientists. And I think it's quite important to identify those early on in people's career. Not every clinician or every wants to be a researcher, but I think some do. And I think it's important to identify them early and find time for them to build up their research skills. In the US, for those interested in research, at least in surgery, residents or registrars get 2 years to hone their research skills. And I know here in Africa, we don't all have that. The second, of course, would be to have the African-based researchers lead their own scientific projects, publication with local authorship, discussed that before. Number 4, and I'll touch on this again, I think this is really important now, to lead grant applications. There's more and more recognition that from an LMIC. And I think this is a real chance for African researchers to get in the game. Because by doing this, you will learn from your high income colleagues and then eventually be able to lead one all on your own. The next is developing local infrastructure. And I think this is what costs the most money. And I think this is maybe the hardest for grant funding to fund. But I'll end with an example of how this has been done, is that local universities really need the money and the investment to build up solid research groups. So again, this includes statisticians, this includes folks to run the projects, this includes money to help manage the finances, this includes grant writers as well. And I think that without that, I don't feel that here in Africa, we are going to be able to compete on the international arena. The next is to engage local communities. I think that this is something that's really improved a lot, but I do feel that trying to understand your study population will really help make research relevant. And again, I think the advantage of those of us working on this continent in global health research is that we are much closer to the communities than our high-income colleagues. And then the last one would be to produce new knowledge and influence policy and practice. So I think that all this research is useless if you don't actually make a change on the policy or practice in your own country or in your own region. So I wanted to end, this is my last slide, to talk about some very successful funding of African-led research. And this was external funding. So the first is an example from the NIH from the US. So there have been two programs there, MEPI, which has been funded by $135 million US, and this is to train local African scientists. And the other one is the Human Resources for Health grant, sponsored in part by PEPFAR and in part by the CDC, and that's been given $180 million. The other one that I'll go into a little bit more detail on is through the Wellcome Trust, the UK government, and the Gates Foundation. There has been money into what's called the Deltas African Initiative. This primary objective is to help build infrastructure and train local young African scientists. That money has been mostly given to the African Academy of Science, and the African Union Development Agency helps to manage that. But the idea is to really have the ideas generated from African scientists themselves. One small branch of that is SAMPI, the Sub-Saharan Initiative around TB research. So they received $11 million US, which in terms of grants may not seem that big, but they have shown in the last 5 years, they've managed to have 119 publications. And most importantly, they've trained 105 African fellows, including masters, PhDs, and postdocs. And of these publications, 42 have been first authors by these fellows. And so this is, in my mind, a very positive example of how, starting with external funding, African scientists can be really trained up. I also want to mention that the whole Deltas initiative is also to put money into the infrastructure of the universities with which they work in Africa. And I think that's really important. A lot of this funding, at least historically, has been going to communicable diseases such as TB, HIV, and malaria. But I think Rupert and Bruce's example of their most recent grant, congratulations on that, shows that the tide is changing, and that studies like ASOS and studies by Global Surge can show how important surgical care and acute care conditions are as well. And we certainly hope that in the future we would be able to tap into some of these. That is the end of my talk. Just want to say that Global Health has put a focus on African healthcare, but Africans need to lead African-based research. We need to drive our local agendas, develop our local research capacity, and harness equitable high-income and low-middle-income partnerships. And finally, succeed in independent grant funding. I would love to entertain any questions, as well as to hear if any of you have ever had any of these experiences, positive or negative, that I have shared. Thank you very much.
Thank you. Now the floor is open for questions, opinions as well.
May I ask a quick question to Anish?
Yes, of course.
Catherine, I thought that was an absolutely fantastic talk. Thank you so much. And sorry for overrunning on mine, by the way. I couldn't find my clock and I didn't know how long I had been speaking for, but then I found loads of messages from Turanesh to shut up. The issue of credit for research going to the people who deserve that credit is so important. What do you think people like me should be doing? I mean, I'm sitting here in London, and I'm a co-author on lots of global health research, and I worry a lot about whether I am somehow disproportionately represented for the successes that this research delivered, when actually often I feel like people are doing the real work and people in the hospitals themselves in Africa. What should people like me be doing so that we get that balance of helping and taking credit right, that we don't take more credit than we're entitled to?
Yeah, thanks for your question. So I would probably answer that in two parts. The first is like, how can we be helpful? And I think that at least in my experience, so maybe not for yours, sometimes the partnership starts with the high income person with their own, they have a grant and they have an idea that they bring to the LMIC researchers. And they do make a big effort to ask, like, is this something you could do? Is this something you'd be interested in? But I think that's oftentimes the answer is yes, 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 because the LMIC researcher wasn't quite sure how to think of their own idea or didn't have a grant that they could also apply for. I had just no idea how to apply for one. So I wonder now, if you're in the position, if you could perhaps start more open-ended with some of your colleagues. I mean, I think Bruce is a shining example because he certainly isn't a person who, has any of these deficits in terms of research and has his own ideas. But ask your research partners, what are the gaps in your own research capacity and how could we support that with the next grant? Because I know that some grants are purely about research capacity building, but obviously you have projects tacked onto that are ongoing that you do in order to build the research capacity, but some grants are specifically for capacity building. So perhaps just to ask, like, what is it that you're shortcoming? Is it stats? Is it you have no idea how to design your own project? Because I'm sure that there's a lot of clinical ideas. And then I guess the other question about the credit, I would turn around and ask you, what do you think you should be doing about that?
Sorry, I mean, I genuinely sometimes think that that we should just be helping and not getting any credit at all. It's a real quandary because to some extent the driver for the money is the university in the UK getting an academic success out of it. And so for me, the academic success is a lever to get the money and to use my university to get the money. If the university is getting an academic success, they don't mind me applying for the grants and spending it in Africa. But I also know that for a lot of people in any country who do a lot of the work on the front line in terms of research, seeing some person who at the top is getting the credit all the time can sometimes be very demotivating.
And I think, and I think that there is a real, not a conundrum or tension, but I think we do have to acknowledge that the way the systems are set up in the UK, the US, is that you cannot be completely invisible. Otherwise, you'll never get the next grant that you want to use to help build more capacity. So there is a group, CUGH, the Consortium of Universities for Global Health, and there's a specific committee about academic promotions around global health research. And the exact question they're trying to tackle is there a way to change the tenure track requirements for global health researchers? Because by definition, if you are trying to capacitate your colleagues in LMICs, you are losing points on your own first author, last author, for example. Yeah. And is there a way to give credit for time spent teaching a course, but no publication out of it, or time doing, helping someone else get a grant that still would credit you because it's still, you still have to survive in your own context. But this committee is quite interesting because it has quite a few associate deans for teaching and learning in the US, at least. So perhaps they can change their own policies. But I think for now, it is a conundrum, yeah.
Could I just encourage you to keep talking about this issue? Because the people who need to say this are people in Africa. Please keep highlighting it, keep talking about it. Don't be worried about offending, just bring it up more, and it will be much easier to solve it when people are more aware.
I see that there's a hand up. There's also a couple questions in the chat that were sent directly to me. Should we go to the hand first? I think it's Dr. Tamiro.
Hi, Elon, yeah.
Yes, thank you very much for an excellent presentation. I really loved it. I was going to ask what just Professor suggested. What should be done like in Africa, especially academicians, researchers from Africa? I think we need to have this voice. We need to start like asking how to decolonize this global health arena, especially when it comes to what you have mentioned, the capacity building. It is not happening. It was not happening for a very long time. Even when the concept of global health initiated, it was not for the low middle income country or the global south. It was for the global north to benefit, like to just keep exploiting what is going on in the era of colonization. So even our academic environments are not that alert. And my question to you, I don't know if there is answer to this. What should be done in our mind? I think decolonizing things start in our mind, and what should be done in to kind of this to initiate all what you have been saying, or to have all this energy and to stand up for ourselves, to speak up and say, even though it could offend some of our paternalistic donors and possibly lose grant because of what we said. Thank you.
Yeah, I mean, you make an excellent point, and I'd certainly love to hear what other colleagues speak and say. But I think the first thing is to get our own ducks in a row, or prepare our own backyard. So for example, having local research ideas and priorities set up. So I think that if we have a potential funder coming to you, or a potential collaborator, and sometimes collaborators come with sort of very open-ended and say, we'd love to work with you. If we've got this idea, but if you say, well, we've got these 10 ideas already, and we've already looked at them, and this is what we'd like to do, but we don't have any funding, would you like to partner? I think that would be really helpful. I think the other thing is to know exactly what gaps and deficiencies you have in terms of the training that you want, and if you can, be very specific to your high income partner. Sometimes these relationships take a while, and I think you mentioned a really important thing, the desire not to offend. And I think that I have been working in some places where I have seen that the local clinicians and scientists do not want to offend, and they will allow the high income people to do pretty much anything. I mean, I'll give you one clinical example, so it's not research, but I was working in a place where a very famous vascular surgeon came and wanted to teach dialysis access, so AV fistula creation, and we didn't have dialysis in that entire country. But he wanted to have all the registrars in theater, found a patient, and made this to show everyone, but never once asked, is this appropriate for the local context? But on the flip side, the local head of surgery did not ever say, we don't need this procedure to be taught. We need these other procedures to be taught. So again, it's that balance of feeling like you have the power to speak out. The second thing, and I'll address, because this relates to one of the questions, what are the potential roles for ministries of health? So I'll mention Rwanda again, because they have a very strong Ministry of Health who has set up a specific Rwandan medical board so that every research collaboration or potential one coming into their country gets reviewed by this board. And at the very least, there has to be local authorship on all the papers. But again, as I mentioned, that's only really the first step to equity, because you could just put anyone on the paper. But I think that, as ministries of health, it would be quite important if you were able to help regulate some of this. Sometimes it's just a bit of a circus of all the different groups coming in. I hope that answers a bit, and maybe someone else wants to comment on this too.
It seems that we're running out of time. What will we do? Maybe you respond to the questions on the chat box? Or...
Sure, okay. I'll just take this last one more question. It was, how do you help local researchers when they want to address local priorities to starting operational research in their countries? And I think that this is a real conundrum as well, because often you are a local researcher, doctor, clinician, you have your own problem that you see, but you're not so sure how to get it out to the world, or how to get someone in a high income country or a grant for yourself. And I think that comes down to data collection And Bruce Bickert, I'm sure, will talk about this a lot. But if you don't have data to show the extent of your problem or your outcomes, it's very difficult to tell the world about it. So importantly, even if it's the most basic data collection, try to record and keep that. Because if you're able to do that, even if you're not so sure how to move that forward into a paper, at least you'll be ready when someone wants to come and collaborate with you. And I see Bruce has his hand up. I don't know if you want me to end on him or.
Maybe Professor Biros say something. Let's accept that.
Thanks, Catherine. I just wanted to actually support what Catherine was saying, and on this question in particular. So I spoke earlier on how we're trying to develop this African perioperative network, which is this data, basically a data network, so that we can connect all of us together. And the question about, about researchers and support and that, and the idea with the African perioperative network is that you log into it and you say, I want to do some research on breast cancer. And you can put down, this is your interest. And essentially you can find other researchers across the country, continent who've got similar interests, and you can set up projects yourself to start looking at these problems. And in that way, I think you can also find mentors across the continent who are experts in the field. And so that's a long-term vision of this perioperative network. It's to enable all of us to, initiate projects and do them and build networks of interest groups. That's the first part. And then the second part is about what Catherine was talking about now, about tracking, auditing and tracking what we're doing. And that is one of the projects which has been running in the background, trying to establish a minimum data set for perioperative care and surgery in Africa, which is the Delphi part has been done. So that is in the process now. And the first part would be a minimum data set for tracking perioperative mortality in Africa. So we can start benchmarking our own practice and use it for quality improvements. So very timely question and great to answer, Catherine. And just look out for more. You'll hear more through the meeting.
Thank you all for that. Let's now move on to Dr. Tim. Is there? Dr. Tim Baker will be presenting on on essential emergency and critical care with a global context. You're there? Are you muted? I can't hear. You still look muted. Yeah, yours.
Can you hear me now, Tirunish?
Yes. Now I can hear you. Please proceed.
Okay. Sorry about that. Hi, thank you very much. It's an honor to be here and present today. So I am talking to you from Dar es Salaam, Tanzania, where I am working at Muhimbili University of Health and Allied Sciences and also at Ifakara Health Institute. And I'm going to talk to you today about this topic of essential emergency and critical care and basically follow on quite a lot from the previous speakers to make the point that if we're interested in the care of critically ill patients, we shouldn't mix that up with high-tech ICU care necessarily, that there are opportunities for real impact at the more basic level. So I'll talk a bit about critical illness, the care we can provide for patients with critical illness, and then on to this idea of essential emergency and critical care. All of this is in context. Bruce presented the very nice Lancet commission on surgery. There was also a commission in 2018 on high quality health systems, which is very relevant for everything we're talking about at this conference. And that commission found that there is problems with care very commonly across conditions and settings. And actually, the quality of care provided in health facilities has become a bigger problem now in the world than the well-known problem of access to healthcare. So this commission estimated that if we could introduce high-quality health systems in all LMICs, we could save over 8 million lives every year. And they emphasize the need for research in this area. So that chimes with everything we're talking about today. The area of interest for me and for lots of us, I think, here is these patients who have critical illness. And if you define critical illness in the broadest sense, it's the patients who are sickest in the system, which is the surgical patients, but also patients with other conditions, infectious diseases, maternal conditions, non-communicable diseases, and so on. So it's the sickest patients, or the patients with whose vital organs are starting to become dysfunctional, and they have a high risk of death in the very acute phase if care is not taken. And also an important aspect of this is the patients who have some potential for reversibility. We're not talking about the patients at the end stage of life, the terminal patients. So this is easy to see in a model like this, where you can see the conditions on the left, including the surgical conditions and other acute conditions. When they get sick enough, they develop these different kind of syndromic problems like hypoxia, like shock, unconsciousness, or blocked airway. And it's these patients who are the critically ill ones. How much critical illness is there in the world? It's actually quite challenging to come up with good estimates. There was a recent estimate on sepsis, which is a common form of critical illness, that there are 11 million deaths annually each year. And there's also estimates on how many cases there are, also using methods that have their limitations, but estimates of 30 to 45 million every year have been stated. Different methods that we have used in our group, looking at how many patients within hospitals have critical illness in different settings in the world, has shown that roughly 12 to 18% of in-hospital patients are critically ill, so a very large burden that hospitals are dealing with, and the mortality of these patients is somewhere between 15 and 30%. So it's a real problem in the world. COVID has kind of seen a surge of critically ill patients and of interest around critical illness because of this well-known pyramid that was shown at the start of the pandemic, that these critically ill patients in COVID, who are known as severe or critical COVID, make up about 20% of the COVID patients. So critical illness has never been talked about more in the world than it has in the past 2 years, I would say. So if we move from there to think what is critical care in that way, so the definition I would like us all to try and think of it as is basically any care for these critically ill patients. So it's the identification, monitoring, and treatment of the patients with critical illness. And it often includes the initial and sustained support of vital organ function. So real kind of focus on saving the lives of the patient, keeping them stabilized while we're waiting for the patient themselves or their other treatments to get the patient better. And a model to try and see how this fits into other terms in this field. I would say all of these terms are within the kind of domain of acute care. So we're not so much talking about chronic care. But within this acute care, we have emergency care, which has its focus on the timely care. So it tends to be the care on arrival to hospital, or the kind of quick care needed for patients. But they don't need to be very severe. They can have a non-life-threatening disease. And then you have critical care, which has its emphasis on severity. And these two, of course, overlap. So you have patients who need quick care and are critically ill, and that's the overlapping bit in the middle. And this tries to show that there's a difference between critical care and intensive care, the care in an ICU. Intensive care is then a subset of this critical care. And then intensive care would be defined as the high-tech, high sophisticated, expensive care in intensive care units. So it'll be interesting to hear other people's take on this sort of Venn diagram, and whether it chimes with how other people are thinking of these terms, or whether there are differences in there. What's critical care like currently? Well, we know that there are substantial deficiencies in many parts of the world. There's a lack of systems to provide, this is particularly in COVID, have been highlighted, that the advanced respiratory support, so mechanical ventilation, high flow nasal oxygen, and CPAP in many places. A study from Kenya at the beginning of the pandemic said only 58% of beds were in hospitals with an oxygen supply. So what we know is critically ill patients are most often managed in general hospital wards. And this is a crucial point to think. If we want to improve the care of critically ill patients, we must be looking at improving the care in general hospital wards rather than looking in ICUs, because there's not so many patients in ICUs. If we look at Malawi, particularly, where I worked for a number of years, before COVID, there were 25 ICU beds in the country with a population of 19 million. Which of course is far lower than high income countries. And the whole country only has 5 specialists in anesthesia and intensive care and very few ICU trained nurses. This means that intensive care in Malawi is usually done without arterial blood gases, without capnography, other high-tech devices and equipment, and with very few investigations to be able to guide the care. And actually, the main challenges for the clinicians in these settings is basic things such as the supply of oxygen failing or power outages and equipment breaking down. So once again, the point, and in Malawi, we did a survey and found that 90% of all critically ill patients in Malawian hospitals are outside of ICUs in the general wards. This finding is maybe one of the main ones to as a take-home message from this talk. If we try and think, okay, so how many patients are receiving the care that they need, the critically ill patients, and therefore what is the unmet need in Malawi? We looked at this with over 1,000 patients, and this was just looking at patients across the board in all hospital wards. And of these patients, we found that 45 were at that point in time hypoxic. And of those 45, only 5 were receiving oxygen. So there was at that point an unmet need for hypoxia treatment of almost 90%. And similar findings were found with hypertension, where there was an unmet need of slightly over 90%, and unconsciousness, where we thought that unconscious patients should have some sort of airway protection, even if it means just lying them in the lateral position, in the recovery position. And 53% had an unmet need of that care. Tachypnea as well, so fast respiration, none of those patients were receiving oxygen. So this slide is saying that there's this was pre-COVID, I should say, was a very, very large unmet need for this sort of basic critical care. Just to mention, and I think Rupert made the same point, that there are such different levels of resources for caring for patients with critical care. So the care is not the same as ICU care, and this is not limited to just different countries with different resource settings. It's also within countries. For example, university hospitals often have more resources than regional, which have more resources than district hospitals. And also within the same hospital, you have different resources in the daytime than you do in the nighttime. So if we want to improve the outcomes of critically ill patients, we need to think of what care are these patients getting in the middle of the night in district hospitals. And what we've seen in our research is this is key even in high-income country settings. So the care of critical illness can often have deficiencies in night times in district hospitals and so on. So this led to the development of a concept to try and come up with what is the care that all patients with critical illness should be receiving all the time in all hospitals in every country in the world. So a basic care kind of concept, the minimum standards, that if we could define this, we could then study how much are patients receiving this and what would be the impact of increasing this care. So this concept has been called essential emergency and critical care. And we included both terms, emergency care and critical care, because of the desire to have a patient-centered focus. We want to think of patients with critical illness, and these patients, when they arrive at the hospital, are often seen by the system as receiving emergency care rather than critical care, whereas when they're on the wards, they're seen as receiving critical care. But from the patient's perspective, it makes no difference, but it makes a difference for how the hospitals and how the clinicians are seeing it. So it's the same care in the emergency departments and within the hospitals. We have a kind of model guiding this, thinking that the care for these patients can be seen to increase in complexity and then have different names for those different levels of complexity, so that the essential care is this lowest level of complexity. And it can be in the emergency unit, it can be in the operating theatre, ICU, ward, the very basic care, which kind of forms then the fundament, the basic level for this care. If there's more resources available, then you can take a step up and provide the additional intermediate care or up to the advanced care, which is usually then just in the ICUs and maybe in the operating theatres. So just to be clear that we're talking about this bottom level of care, this essential emergency and critical care. One version of this, we introduced this protocol into a hospital in Tanzania called the Vital Signs Directed Therapy Protocol. So this was a protocol for task sharing between the doctors and nurses, where the nurses would check the vital signs, look at this protocol for whether the vital signs were normal in green or abnormal in yellow or dangerously abnormal in red. And then it guided actions that were then allowed to be done by the nurse without having to wait for the doctor's prescription. So such as lying the patient on the side, increasing the oxygen, giving a fluid bolus. And what we saw when this protocol was introduced was the acute treatment when a danger sign was identified increased on this ICU where it was introduced, and mortality for the patients with low blood pressure actually fell. So this is a sort of basic essential emergency and critical care that we're talking about. A framework to help us think about how this care is provided and where we could have areas to target for improvement is this conceptual framework. If we start over in the top right in that red box, what we're all wanting is survival of the critically ill. And we think in order to get there, these critically ill patients need to have their vital physiological functions stabilized. To get there, EECC is required. So this essential care needs to be given in an effective way to all of the patients. So this is our goal, to increase the effective coverage of this care. And this care consists of two domains. We need to identify the critically ill patients, which is often a big problem in hospitals. We don't know which ones are the critically ill, and then we need to provide the essential care. And in order to do these two things, the hospitals must be ready. This is the structures in the Don-Obedian framework that Bruce talked about at the beginning of this session today. So the hospitals need to have equipment, drugs, human resources, everything in place to be able to provide this care. And then the processes are then needed. So the clinical practice needs to be good, both for the identification and the care. So an example on the left would be for hypoxia, hospital readiness would be the existence of a pulse oximeter and staff able to use it. Clinical practice would then be the use of the pulse oximeter and the identification of the hypoxic patient. So this framework, I think, can be useful for both research, for assessment of current quality of care, and for other things within this field. We then moved on and thought, okay, so we have our concept, we have a framework. What's in this? What is the content of essential emergency and critical care? And we didn't want to define this as a group of researchers. We wanted to get consensus across the world from global clinicians. And crucially, from a very varied group of global clinicians, given that this concept applies to all patients in all specialties. And we needed then the content in these two domains of identification and care and relevant for both these clinical processes and for the hospital readiness. So we conducted a Delphi consensus, which is a method for reaching consensus among experts, and involved with 269 people from many settings across the world. Spread among low-income countries where the majority were working, middle-income and high-income countries, and expertise from emergency care, intensive care, and also from ward-based care, medicine, surgery, pediatrics, obstetrics. And we won't go through in detail, but what it came up with this process, which you can see in the publication, is 40 clinical processes that are seen to be the first line, the basic, the most essential care for critically ill patients. So this includes things like identification, that using triage, using the normal vital signs that we all know well, and also treatments such as oxygen, insertion of nasal pharyngeal airway, and the like. but it doesn't include more complex care such as blood transfusions, non-invasive ventilation, or dialysis. So it has a kind of ceiling on it. And then we also specified what hospitals would need to have the requirements for hospitals to be ready for this, divided up into these different categories of equipment, consumables, human resources, and so on. So this is things such as pulse oximeters, IV giving sets, but not more advanced things that are not required to do those 40 clinical practices. And this work is done within a Wellcome Trust funded project called POETIC, Provision of Essential Treatment in Critical Illness. And within that project, which is currently ongoing, we're investigating the optimal methods for providing quality care to critically ill patients. Projects based in Kenya and Tanzania, and includes many different methods, including policy analyses, surveys and questionnaires, work interviewing and discussing with frontline health workers and other stakeholders in those countries and globally, and also crucially some health economic work to try and understand the cost effectiveness of these different approaches. The full findings will be coming out in the next few months. Preliminarily, it can be said that we found that it's very common that district hospitals and referral hospitals are unable to provide oxygen at high flow rates. So that's the kind of setting where we're in at the moment. And only 17% had one or more ICU or even a high dependency unit bed. The costs of providing ECC to a critically ill patient using Tanzanian costs are approximately $20 per day. Which compared to the costs of providing more advanced care, which are up to about $300 per day. And if we're working in areas where oxygen is a limited resource, then providing oxygen to patients just using simple oxygen therapy techniques can be, the same amount of oxygen can be provided to 6 patients for every 1 who is receiving mechanical ventilation. But there's a lot more findings coming out from this project over the next few months. So what are the next steps? How to implement ECC? So just some kind of guidance of what could be done. So I think it would be an ideal thing for hospitals to start doing assessments of where they are in terms of ECC, identifying them where the bottlenecks for ECC are. Is it a lack of human resources, lack of drugs, or is it a lack of the routines, the processes for providing this care, leading to action plans for how this care can be improved. Thinking about how hospitals are organized, ensuring that severity of illness is a key principle for caring for patients. Often the diagnosis takes precedent, but I think thinking of severity using triage at arrival to hospital, but also regular assessments on the wards is really ideal. Thinking of the infrastructure, the setup for the hospitals, whether they should have an emergency room at the arrival to the hospital, or triage desk, resuscitation room, these sorts of things. Also post-operative recovery rooms or high dependency units. Where should the really sick patients be looked after? Should we be concentrating the care and the resources for them in certain physical locations? And ensuring that these emergency drugs supplies are always available. And one way to do that is to have an emergency trolley or a box, which is always kept restocked in every ward where critically ill patients can be found. And then definitely a big focus on health workers, making sure we have enough health workers with the requisite skills to be able to provide this basic care. And that probably includes both pre-service training and then regular repeated training for in service. And then policy engagement. So make sure that we have, and within the POETIC project, we are doing this, direct feedback to national policymakers. And we've been doing that through the COVID pandemic and also reaching out globally to WHO and other stakeholders. One thing we have, and I think this could be connected very nicely to the perioperative network and to APORG and these other networks we discussed today, is we've set up a network of clinicians and researchers interested in ECC. So the eccnetwork.org, please go in and have a look at that. And if you're interested, you're very welcome to join. And we should think of ways of getting all these networks together, I think. Last slide, future aims. We want to continue to improve the understanding of the global burden of critical illness, get some better numbers there, conduct these bottleneck analyses and understand what's meaning that, what's underlying problems for the world to be able to do better EECC, and then lead to intervention studies, maybe cluster randomized trials, for example, looking at the patient outcomes, but also lots of process analyses and understanding what happens to the system when these trials take place. I think a good way of framing it at the moment is about pandemic preparedness. So I'd say COVID has really shown to us that if the system is not ready to provide EECC, then when a pandemic hits, we cannot look after our patients. And the terrible scenes from India last year when patients were not receiving this care is testament to that. And we want to look at how to implement and lead to policy change. Potential impact, if we really would succeed in getting EECC to everybody, with very rough back of an envelope estimates, we think we could save 500,000 lives globally every year. And the take-home messages are that critical illness is common. There's a large unmet need. If we want to provide care to these patients, then we should be prioritizing this essential care rather than the high-tech care. And if we do this, there really is a large potential for averting deaths. And I've just got a series of resources there that I can send slides to anyone who'd like, and you can see all these different resources. Thank you very much.
Thank you, Dr. Tim, for another exciting presentation. So we have another 10 minutes for questions, opinions. The floor is open for questions. Let's take 10 minutes for discussion, then we will break for lunch. Munir, you're raising hand. Maybe you can unmute yourself and proceed. From
no, I was just appreciating the quality of presentations and saying thank you. I have no question.
Okay, thank you.
वीडियो लोगों को निशाशिश ये कर रहा था
Okay, Professor Bruce, I can see your hands. Proceed.
Thanks. Thanks very much, Tim. I think Tim's talk illustrates, if we go back to the whole Donabedian concept for quality of care, that in the environments we work as clinicians, the processes which are in place improve the quality of care. And so the EECC work shows it quite clearly. It's about trying to implement processes to make care better. And similarly, the work in ASOS2 showed it was probably our lack of ability to implement processes which contributed to us not being able to improve the quality of postoperative surgical outcomes. So as clinicians, if broadly speaking, we need to be working on implementation of processes which ensure safe acute care. And as governments and hospital administrators and that need to be working on resources to ensure that what we do is enabled. So processes will only get us to a certain point, and the ceiling will be the resources that are available to the clinicians. So I see this, if we want to improve quality of care in our environment, which say in a low resource environment, as clinicians, we need to focus on processes and we need to advocate for resources. And as administrators and leaders, they have to spend the time looking towards enabling resource generation.
Yeah, thank you for the. So if there's no question, let's break for lunch. It seems like some of the people has already left. Let's break for lunch, and we have 1 hour for lunch, so we'll come back at 2 p.m. from now. So we have 5 extra minutes. So if there is any question that when you want to send to Dr. Tim, you can put on the chat box or directly send it to him. Thank you.
it is time. I hope everyone had a very good lunch break. For those who are having lunch, for those who are from another time zone, I hope you had a very good break. Before I start, there is an announcement about live streaming of this program over YouTube. For those who are on YouTube, you can drop your questions after the speakers. It will be addressed. Yes. So this morning we had an excellent time, and we do have more coming this afternoon. Our first speaker is going to be Professor Yifru. Professor Yifru is a medical specialist, gynae obs specialist, and especially trained in leadership and governance. Professor has more than 24 years of experience working as a clinician and university instructor, researcher with more than 100 publications, and a mentor for quite a lot of PhD and other students. And he is known for his public health leadership. He was a dean and vice president in Awasa University, and also in Addis Ababa University in a different time. And he was a former minister of Ministry of Health in Ethiopia. He has been engaged in different consultancy roles, both for national and especially academic institutions in the development of national strategies, guidelines, and different manuals. Currently, Professor Yifru works as a senior researcher and consultant at St. Paul Millennium Medical College, and he is currently working as editor of BMC Pregnancy and Childbirth, the postdoc and fellow research advisor and chairperson at EPHI, and he is board member for both Jimma University and Jimma Institute of Health, also technical advisor, part of technical advisory group for World Health Organization. It is privileged to have Professor Yifru. Unfortunately, Professor Yifru is not making it in person, so we do have a video pre-recorded presentation, and we'll go to that.
Everybody. Okay. Good morning, everybody. The topic that I'm given to this morning's talk is on building perioperative and acute care national research capacity, specifically on research impact, research challenges, and possibilities. I'll not be focusing specifically on acute care and perioperative care. I'll try to touch the overall research undertaking in Ethiopia. So this is my presentation outline. I'll not go to one by one here, and let me start with some introductory remarks. In general, medical research in Ethiopia is still at grassroots level. Only limited number of professionals are engaged in doing research, and mainly this is for academic career development. And the articles that you may find online are mainly extracts of postgraduate student thesis, and our international collaboration is very limited, and the research outputs with good strengths of evidence are very low. This is despite the fact that medicine is an ever-changing science, and many of the academia may be engaged in clinical service provision and teaching. However, their engagement in research is not as such to what is expected. Therefore, faculty and healthcare workers need to teach and practice based on evidence. And this will be possible when they are engaged in research. No one will be up to date unless he is or she is engaged in research. This is what I believe. The research impact, well, it is clear, but just to highlight some of the points. Research findings with good strength of evidence is an original contribution to the existing stock of knowledge. It's vital evidence for policymakers and programmers. And it's an academic excellence, of course, for the institution and as well as for the researcher. It is clear that it is research and the technology what has changed the world. And the world some century back was quite different from what it's today. And this happened because of the technology and the research undertaking globally. It's the research what makes us even an active learner. So as science grows, and we grow also parallelly when we engage in research. When we do research, this is what my understanding is. When we do research, we read the world, and the world reads us. And in general, attaining excellence is possible by translating evidence into practice. Challenges is easy to talk, but difficult to solve. And particularly in low-income countries like Ethiopia, the challenges are a lot, and some maybe because of the mismanagement of resources, and some are actually due to scarcity of resources. The lack of researchers as a model and a supervisor may outweigh the resources, and because when people are working on research and other projects, they are likely to mobilize resources. So the lack of good researchers is what is limiting our engagement. Laying the ethical clearance at the national level is another hurdle, and very, very challenging to have collaboration with international researchers and doing some impactful researches with those who have credible experience in research. So the national law that we have in this country is, I can say, not facilitating, rather blocking the type, particularly if the research is on randomized controlled trials involving children and pregnant women. It's almost impossible to do that kind of research. Whatever the trial is, even in the micronutrient supplementation, which is highly recommended, and which we have credible evidence from other countries. Therefore, limited experience in developing a competitive proposal for grants that we have, maybe another limiting factor. And these are some of the challenges what really limiting us not to engage in the research. What can be done? Well, there are many issues that can be solved at policy level and at the facility level, at the research institute level, and then the building a capacity of the researchers and conducting impactful researches may have maybe some of the solutions. So we have to also grow with the digital technology in terms of accessing as well as utilizing. It's not only for doing research, but also for teaching. The digital learning is becoming popular thanks to, may I say thanks to the COVID-19. So this is another important area we need to work hard. What can be done? Again, establishing research resource center is a very good solution in my assessment. This is a kind of unit well equipped with audio and IT facility. Each university needs to hire senior researchers who will be dedicated only for assisting junior researchers and postgraduate students. Therefore, they can assist researchers, junior researchers in proposal writing, accessing and utilizing electronic data and journals, data analysis, write-up and dissemination, that is up to the publication. So these are professionals who can make a difference in each university, what I think is possible. And another one is many of the academia have a difficulty in accessing or following some calls, and so hiring professionals will be assisting in grant writing, call hunting, and language editing. Definitely will improve this engagement in research. Establishing research resource center is also to support research training, manual development, and additionally engage in soliciting funds. There are local sources and as well as international sources, financial sources that can be utilized for research undertaking. Apology. Let me close this. And as part of the Research Resource Center, it is important actually to establish a research IT system for researchers that they can utilize to access data and also to conduct analysis. Another important thing is implementing the electronic medical recording for the researchers to have access to hospital and as well as community-based data is another important input that can make a difference in research undertaking. Assisting in improving the procurement process is another important milestone. Researchers usually complain because of the difficulty in getting the right time, the budget, and the right time liquidation, and also very difficult part of the procurement process that we have in this country is really a hindering factor. Building the research capacity through training and practice is another important thing that we need to carry out. This can be done by cultivating the local potential and exploring international opportunities to uplift the research capacity of faculty and postgraduate students. And it is not as such difficult to organize inductive trainings on grant writing, protocol development, management of primary data, and secondary data analysis. What's important is having an office that can mobilize such kind of activities and make a reality. Involving senior research co-advisors for postgraduate students from outside universities. This can be from the national resource, can be from international source. So this is another important point need to be considered too. to fill the gap. Promoting and supporting multidisciplinary problem-solving research projects, again, should include integrating basic science research with clinical research to the best. Public health, basic science, and the clinical research researchers has to work hand in hand, and this may be facilitated through, again, the research center. Leveraging the technological resources for research. There are, these days, it's not in the old time. Technologies are advancing, and little effort may bring about a huge change. So what's important is engaging and uplifting the knowledge and the skill of the potential researchers. Another very simple but important is promoting systematic reviews and meta-analysis, whose cost is minimal, but their impact is global. As you know, the best evidence is meta-analysis of randomized clinical trials. So to have the best evidence, that is in terms of strength of the data, to have an impact on the programs and the policies, this is simple that we can do, and we can teach also researchers how to do it. Aligning and supporting the research works and the innovations with the national health and health-related priorities. Yeah, this is to support the national program, the health program. The Ministry of Health and Regional Health can utilize our research products, our research outcomes based on, if you are interested and if we are engaged in their research priorities. Creating an international research link and a collaboration to conduct highly impactful primary researches. Yes, learning from others and evolving others and making it a collaborative type of research. Yeah, that is what the world is doing. And many developing countries, that's the kind of experience they have. But here, because of the national law, our engagement is very limited. Therefore, to establish a triangular research partnership like South-North collaboration, and this will be evaluated as a good collaboration, and likelihood of winning international grants is very high. And giving a special emphasis to sustainable collaborative research projects. That's how universities grow. There is no university in the world that becomes renowned without having such sustainable research projects. So this is how our university should also grow. Integrating research ecosystem. This is by collaborating across disciplines within the university, and the external partners, and involving stakeholders, and communities as well. It's also important to integrate the postgraduate research with the staff research and the thematic research areas. Everybody is doing little alone, not collaboratively or jointly. So this kind of efforts are not as such fruitful and may not take us anywhere. So to have an impactful research and to make a difference in our research endeavors should be integrated type. Developing research projects, enabling developing several daughter protocols is such an outcome. When a research project is longitudinal type, and that can have multiple daughter protocols and multiple research outcomes, I think that's where we're lacking. Establishing a core research lab that can serve for all. Every basic science researchers are doing their best by establishing a standalone research lab. This is not good. Rather, having a core research lab may serve for others and help us to do more and jointly. Abridging the bureaucracy in health research for postgraduate students. This is clear and may take time, but whatever the case, that's where we need to act. Directing postgraduate students to focus on the university's research thematic areas. I think this is a strategy, should be the strategy and should be taken seriously. Still, with all these facilities and inputs, if researchers are, particularly academia are not engaged in research, I think this is a time to implement the publish or perish rule. Every university develop legislation, and in every university legislation I have reviewed, found that this publish or perish rule is there, but it's not implemented. So let's create a favorable research environment in the hospital as well as in the community to academic staff to let them intensively engage in research by establishing a resource center, applying the 40-40-20 working time allocation. This is what it means, is 40% for clinical service, 40% for teaching, and 20% for research. This is equivalent to around 53 days in a year. That's a lot. That's a lot. As somebody who will be engaged in, this is in the legislation, by the way, this 40-40-20. And if somebody is given this number of days as per the legislation, why not is able to, or she is able to produce 2 to 3 articles at least in a year, if not more than that. So if he or she failed to do that, there is room again, up to 8 years, if somebody could not promote from lecturer to assistant, from assistant to associate professor, from associate professor to full professor, this period, that person has to be warned, should be given a letter of warning. And if he couldn't do it, this time, the contract has to be terminated as per the Senate legislation. One more undertaking that can be done at the national level is formulating a national research law. First one is giving a full mandate to universities for ethical clearance and follow-up. Currently, any research that involves 2 or more researchers, 2 or more countries as researchers, the ethical clearance is from the national body. And any clinical trial, be it locally generated or collaborated with international researchers, again needs national ethical clearance. Imagine in a country where 115 million people and more than 50 universities are operating, how is it possible to have such kind of ethical clearance as soon as possible? That's why ethical clearance is taking 6 months up to 2 years. This is blocking my assessment. This is what has been observed in the last decade in particular. Therefore, universities should be mandated to have to give an ethical clearance as they have owned their own, as they owned a strong institutional board. Second one is developing a differential financial management for research. This is a headache. This is a headache for many of the researchers because of the lengthy and very bureaucratic financial management. Researchers are not interested to get engaged. And therefore, last one is mandating universities to establish linkage with universities abroad and to collaborate. They have to be mandated again. As a strategic move at the university level, maybe developing strategic plan for research, bringing the importance of research to the attention of the academic staff, and setting and supporting research priorities can be considered. I would like to summarize my presentation with this schematic figure. This is these are all my ideas. What I believe is, without big mind, there is no big country. Without big academic institution, no big mind. And without big research, no big academic institution. Without big international grant, no big research. Without motivated faculty, no big grant. Without good leadership, no motivated faculty, and without good strategic plan, no good leadership. That's how I see the interlinking or the interconnection of the policy with research undertaking. Thank you very much. Apology for failing to respond to your questions, and have a great day. Thank you.
I thank you, Professor Ifru. So as you just saw on the video, he is not able to join us, and the questions, reflections you have, we will try to entertain among the participants. If you have questions or discussion points, please put them in the chat box while we are having the next speaker. And at the end of the next speakers, we will try to entertain all those. And possibly from Ministry of Health or any academic institutions, Professor Ifru has raised a very significant challenge that that should be addressed, and if anyone would like to possibly address some of the issues he raised, the possible or the future progress that could happen and all that, then we will come back to this discussion if we get any response. Our next speaker is Professor Bruce, and I'm not going to introduce him. He was introduced in the morning. Professor, the floor is yours.
Thanks very much, Hailu. Right, afternoon, everyone. FITSM and the N4PCc have asked me to talk about this topic, the experience we've had from ASOS and ACOS, and the need to develop African acute care collaborative research capacity. So in this talk, it's really two parts. Firstly, just talking about the experiences of ASOS and ACOS, and the sort of points I want to raise are that generosity goes a long way, that we have the capacity to do large-scale, high-quality research, that the global community actually cares about us in Africa, and we care about Africa, and then finally, why there is a need for acute care collaborative research in Africa. I've discussed the funding of all the research this morning. So firstly, just a quick note about generosity and what it can generate. So I think a lot of what we're talking about today is through the generosity of Rupert Pearce. I was fortunate enough to be at a meeting in London. It's quite a long time ago now, when Rupert presented the data for USOS, the European Surgical Outcomes Study. And the simplicity of the work and the pragmatism was very attractive to me. And I didn't know Rupert at the time. I contacted him and I said, I really like the work. I really would like to be able to replicate it in South Africa. and he basically shared all the resources with me, even provided a database for us to help us run the study in South Africa, and that was called SASOS, South African Surgical Outcome Studies. And from that came ASOS subsequently, and the future work. And really that was just through pure generosity, and not knowing me at all or knowing any of us. And it was that generosity which is, I believe, led to where we are now. So just thank you to Rupert. The second thing is, I do believe we have the capacity to do large-scale, high-quality research, and I'm going to give you some examples. So when we did ASOS, the first project, we recruited over 11,000 patients, 247 hospitals across Africa from 25 countries. This was basically established cold from a network at that time which didn't exist. We look at ASOS-2. This was conducted over a year between May 2019 and July 2020. In ASOS-2, 28 African countries, nearly 29,000 patients were recruited into a clinical trial and 332 hospitals. If we look at ACOS, the African COVID-19 Critical Care Outcomes Study, 10 countries, so this is in the pandemic, 10 countries, 64 hospitals, over 3,000 critical care patients. If you put these three projects together, as a group, we've recruited over 43,000 patients into collaborative studies, which essentially have been unfunded. If you look at the countries that have participated, so far in the three studies, 33 countries, and at the moment with ASOS beads and confirmed countries, at the moment, you could say the network is now 38 countries with the inclusion of countries such as Liberia and Somaliland as well, which is extremely exciting, I think, for the network. I just want to highlight ACOS and our capacity. So considering that this is in a pandemic, we recruited over 3,000 critical care COVID-19 patients. At the same time, we did a meta-analysis to put our data in context. These are all the studies that are, at the time, provided definitive COVID-19 critical care outcomes. What I want to point out that the work by ACOS was the fourth largest cohort of any study published. That's the first thing. And the only continent that provided the three bigger cohorts was Europe. In other words, our work exceeded all the other continents, including North America. So, I mean, I think this is a phenomenal work by the group. The next point I want to make is that the global community cares about Africa. So let's look at just some of the startling findings we've had in the work we've done. So the first is on the number of specialists or the workforce density. 20 to 40, as I said this morning, per 100,000 is the recommended minimum standard. ASOS shows us it's less than 1 in Africa. The second thing we know is if you have surgery in Africa, you're twice as likely to die. The third thing is that we know when you look at failure to rescue, death following complications of surgery, twice that of the global average. You look at failure to rescue in a more acute situation in obstetrics or cesarean deliveries. If we look there, what we see is that the complications are about 2.5-fold in the African cohort compared to the US. And when you look at the mortality, it's 50 times higher in Africa. So if we look at failure to rescue for adult surgeries in Africa is about twice the global average. If we look at cesarean sections, where the mortality is 50 times and the complications is about 2.5 times the US, failure to rescue following cesarean deliveries in Africa is 20 times higher than that of a high-income country. And I think what this speaks to is how devastating failure to rescue is when there are acute complications such as bleeding. Also, I wanted to look at the findings of ACOS. So in ACOS, when we did the meta-analysis, what we saw is that the mortality for COVID-19 critical care admissions globally was running at about 31 per 100 admissions. And you look in Africa, our mortality was running at nearly 49 per 100 admissions. 1 in every 2 that's admitted died. This is an excess mortality of nearly 20 deaths per 100 admissions to critical care. Then you look at the resources in critical care. I think for me, the most striking is that in a critical care environment in Africa and in the sites that participated, so we would assume these are very well capacitated sites because they could participate in the study. Only about 8 or 9 of every 10 patients in the critical care has pulse oximetry. I mean, the resources are clearly totally inadequate. And then when we estimated therapeutic interventions such as dialysis and ECMO, we estimated that the provision was about 7 to 14-fold less than one would expect for the severity of the disease in Africa. Why do I say the global community cares about Africa? Well, you look at all those results and they're distressing. Not once has anyone spoken out badly about the results or pointed fingers at us. In fact, the global community have been very supportive of the data we have presented. In fact, they've even shown their support. So the evidence-based perioperative medicine group, what they did is they ran a fundraising initiative for APORG at their last World Congress last year. And it was through donations of delegates to this meeting that they raised the money, which has now become the African Perioperative Network database, which I've been telling you about, and the QR code that you can see on the screen now. So certainly what we're doing, the global community believes in and cares about. The next thing is, I think what our research shows is how much we care about Africa. So if you look at ASOS, after ASOS, we asked clinician researchers who participated in ASOS, would they participate again? Now, I just want to put it in context. So the first thing is, we know these are people working across the continent where there's less than 1 specialist per 100,000 surgical operations. Sorry, less than one specialist per 100,000 population, 20 to 50 times less than the recommended minimum. So they're providing a service in a very austere environment. The second thing is there's very little research capacity, and most of these people do not have any research assistance, and the research is unfunded. And I think this is the most astounding responses that you get. Did you find participation in ASOS valuable? 9 out of 10, yes. Would you participate in similar research in the future? 9 out of 10, yes. Can your hospital participate in future unfunded studies? 9 out of 10, yes. It's a very powerful, positive response from clinician researchers in Africa. And then the free text responses in that survey also offered a lot of insight. By my participation, I want to help my continent. ASOS served as an eye-opener to the possibilities and benefits of interdisciplinary and multinational research. I love collaborative research, and only Africans can tell the African story. What about our response to the findings of ASOS? So we know that we got limited healthcare providers. We know our mortality is twice that of the global average. We know that nearly all these deaths occur post-operatively, and there's a large proportion which is due to failure to rescue. So what we did is we thought if we can, so I suppose the first thing is most of us were astounded, and we could not actually accept the excess death that we knew was happening. So in a quick response, we thought if we could reallocate human resources to those at a higher risk and increase post-operative surveillance for those patients, we may decrease failure to rescue and perioperative mortality. So a study design was set up, extremely pragmatic and massive sample size, because we knew following patients once they leave the hospital is impossible. And we also knew verifying outcomes besides death are extremely difficult in a low resource environment and unfunded environment. So huge sample size for in-hospital mortality. And we delivered that trial. And what we know now is that with the work we've done before, that there really is a massive need for acute care collaborative research in Africa. So if you look at ASOS-2, so the trial was conducted, and unfortunately there was no difference in post-operative mortality between the intervention group and the standard of care group. But we know failure to rescue is a problem, twice that of the global average in adults, and 20 times that of high-income countries in women who have a cesarean delivery. And if you look at the process evaluation for ASOS-2, we made two assumptions. We made the assumption that if we allocated a increased surveillance appropriately, in other words, to those who are more high risk than low risk, that we wouldn't increase the burden of work on the healthcare providers. And the second assumption we made is that we would be able to detect earlier complications in these high-risk patients before they went on to death, and we would be able to escalate the care and provide timeous interventions. So that was the program theory. So then why could we not show benefit? So in reality from the trial, we can't determine whether the intervention arm received more post-op care. We can't determine whether we identified complications earlier, nor can we determine whether the escalation of care was appropriate for the complications. Similarly, we can't determine if there was co-intervention in the standard of care arm, because in ASOS, the mortality was 2.1%, and in ASOS-2, the standard of care mortality was 1.3%. And then when we look at implementation fidelity and the fidelity of conducting the intervention in the trial, we find that there were other factors which were contributing to its fidelity, and these included teamwork and leadership, and also running dummy runs or testing the intervention before the study. The other finding is that in the critical care environment in Africa, we really don't appear to have sufficient resources to respond to acute deterioration. And again, I just want to highlight the point that, you know, in a critical care environment, if only 8 out of 10 patients have a pulse oximeter, this is really far from appropriate. So the question is, certainly there's a signal of failure to rescue. There's a signal of increased mortality. There's a signal that failure to rescue is worse in the more acute complications, such as we see in cesarean deliveries and in critical care. And so really, is there a need for quality improvement work in this space? Do we carry on and try and provide enhanced post-operative surveillance from a quality improvement implementation project? So there are 3 questions, I think, is, should we do it? Is it important? And how would we do it? Should we do it? Certainly. Because we know mortality is twice that of the global average. We know failure to rescue is twice that of the global average. And we know almost all the deaths are occurring in this post-op period where the complications occur. Is it important? Well, as a group, we certainly believe it's important. So in the process evaluation, we asked all the hospital leaders a whole lot of questions. And the question that got the highest positive response was the following: I predict that the ASOS2 interventions will be effective for reducing post-op mortality in my setting. In other words, the participating hospitals in ASOS2, 332 of them, believe that increasing or enhancing post-operative surveillance is a very important intervention to decrease failure to rescue. How would we do it? The data suggests from the process evaluation that if we want to improve outcomes in Africa in these acute conditions, in fact, they are complex and they need quality improvement projects. And this is sort of where we are now, looking at ASOS QI and trying to develop it for a QI project for enhancing post-operative surveillance. So in conclusion, I think our data shows quite clearly that there's a need for acute care collaborative research in Africa. And I think we also definitely have the capacity to respond to this need and develop the high quality research that's needed. Thank you.
Thank you very much, Professor. Participants can ask questions now, and we will entertain questions. You can raise your hand, and if necessary, you can just unmute yourself and speak. While waiting for participant, Professor, I do have a question. Thank you for a very excellent presentation. My question is, so you mentioned we do have lots of problem at our hand from just this study where we have enough evidence saying there is much going on, and quality improvement is going to be the best solution we have. And I'm just curious about the project, the quality improvement project your team is designing. How are you planning to integrate with national previous efforts, like most of the country, I believe, will have this quality improvement concept. They do have as a national plan or a strategy. And how do you plan to integrate this project with the national efforts?
Thanks, Helu. So, Helu, on the perioperative network database, what we want to, if once one goes in there, all the projects are loaded, and we've asked people to indicate interest in the quality improvement project. So they're individuals and sites from a number of countries who have already indicated interest. So it's basically like a two-stage process. The first being a pilot development phase on quality improvement and implementation, and the idea that participating pilot sites work locally with the concept of one, do the sites believe in the hypothesis? In other words, so there's an educational and common vision initial part, which is, do we believe that most deaths are occurring in the post-op period because of failure to rescue? And once, if that educational component is agreed upon, then moving towards what are the processes which are driving this failure to rescue and mortality, and then how can we address it at the local site, and in embedding processes of care which ensure that there's early identification, that there's appropriate intervention and appropriate care of the patients. So, and the idea is to build multidisciplinary teams, because that came through also in the process evaluation, and in the few successful implementation programs in the literature, in the sort of surgical literature in low and middle income countries, certainly multidisciplinary care teams are important, and this is what you're talking about. And it's about nurses, doctors, administrators, managers, and I think it does talk to your point about if they're already established quality improvement teams, either within a hospital or within a country, it would be fantastic to have them on board in that process, because ultimately these, it appears that most of these projects fail if the team fails. So you can set up a beautiful project in a well-resourced environment, and it can still fail. And I know Rupert is on the call, but one of the real classic, I think, examples is APORG, which was the NHS quality improvement project for emergency laparotomies. It really is a fantastic project. All this best practice for pre-intra and post-op care, yet 90-day mortality did not change. And the process evaluation, a lot of it comes down to things about leadership, teamwork, audit and data presentation, and how it's communicated. So certainly, yes, countries and hospitals with well-established QI projects or teams would be very beneficial in this pilot stage. And then if, through the pilot stage, if we can show proof of concept through these different teams in the hospitals, and then take common principles and try and put a package of care together or packages of care together to propose for Africa and then test it at a continental level. That's the plan. Does that, Haley, I'm interested to hear your thoughts. Would you agree with that?
Yes, that is actually what I'm thinking. I mean, the concern is like when it comes to quality improvement, usually with different project comes a different innovative idea. There is this sort of pseudo innovations around quality improvement, and in my experience in Ethiopia, different partners get to involve in quality improvement projects, especially concentrating in a different it could be maternal and child care, it could be surgical, it could be whatever programs that organization engaged in. And with that comes like different thinking, different model. And those models, when they reach the ground, it usually end up confusing the frontline workers, having a different language, having a different implementation mechanism. And that is just my concern, because it is wise to channel every project that comes through what is existing nationally. That existing system might not be strong, existing system might not be functioning to the extent we want it, but ultimately to what you said, whatever novel idea we have, it is going to fail if we don't actually work on the implementation through the team. So yeah, that is my thinking, and it is really wise to go through whatever fragmented effort that exists in each country.
That's very helpful. Thank you, Eddie.
Yeah, I don't see any question. Maybe I don't see on chat, and there is no on YouTube as well. Maybe if I may, I would ask one last question, sure. Then we would shift to the next speaker. Okay, somebody raised, and I think we'll give that chance.
So that's Lemlem. How about the strategies to maintain the sustainability of QI projects? Yeah, thanks for the question. It's a very difficult question, especially being at the beginning of the process and not towards the back end of the process. So the first is, I suppose, the reason I find it difficult, because I'm not even sure. I imagine the QI project is going to be quite, it's going to be the biggest project we've ever tried. It's going to take a lot of work. It's going to take a very different strategy. You know, the work we've done to this point is predominantly quantitative, and now we're going into the field of qualitative work as well, with a quantitative element, and also about QI projects in our environment are going to each, like Haley was discussing, each site will look different. So it's how do you develop a quality improvement project which is broadly generalizable, but at the same time totally unique to the site where it's been implemented. And so to do all that and show that maybe we can improve the quality of care, only after that will we know if we can sustain the project or can address the issue of can we sustain the project. So I can only talk from a theoretical perspective. Again, looking at all the literature on successful surgical implementation projects in low middle income countries, the data is actually very limited. The ones which have shown what they call sustainability, they've only had sustainability in the 3 to 6 month period. I think what we have to accept is once you go down this road, It's not something that you go in, do it and leave. This has to become a culture for the environment in which we provide care. In other words, if we believe most of the deaths are happening in the post-op period, and a lot of it is happening because patients, their complications are progressing, eventually the culture must be that we routinely audit the outcomes in the post-op period, and we audit the processes associated with ensuring that we are identifying patients who are deteriorating early, audit the processes that the interventions offered to these patients are appropriate for the complications. And once that is part of the culture and the ethos of where we work, it has to be maintained. And that comes to the next part of the importance of us establishing, you know, at the very beginning now, a very simple perioperative mortality database across the continent, where we got very simple risk factors, so we can at the same time track what's happening in our hospitals. We can also risk adjust appropriately what's happening in our hospitals, and then we can see the effects of what we're doing also at a hospital level. So it's a complicated story, but I think when one thinks about sustainability, I believe the only way this will be sustainable is by creating a culture of continually doing the implementation work which has been shown to change outcome. And reflecting on processes and outcomes will also mean that we will refine the processes as we go along so that they remain appropriate to improving the outcomes of the patients. Does that make sense?
Thank you. I think we do have another question.
Yes, thank you, Bruce, and hi, Lou. Very good points. It's Luigi here representing Critical Care Africa Network. So much learning for other networks. I mean, the work you've done is massive and unfunded. That's really tremendous. Just wanted to ask you, what do you think is a message for the critical care and ICU research community in Africa? Are large multi-center, multinational trials on quality improvement initiatives a way, or should we focus on different designs? What are your inputs?
Okay. Thanks, Luigi. Again, the first thing is I'm not an expert in critical care, but there are lots of experts on this group, I know. But my feeling is, I'll tell you my philosophy. So the biggest problem we've got is that we know the outcomes are bad for so many different reasons, but I mean, driven predominantly by a lack of resources. And the amount of funding we have is small. And so I think we have to go for big wins, which are simple and generalizable. My advice is, what are the easy things we can do which generalizably will make a big difference at a population level and are easy to implement? So if you just use, I mean, if we just go back to the surgical sort of understanding we've got from ASOS, is that we know most of the deaths are in the post-op period. So that's where if we in that space, that's where we need to focus. And also because we know we can get access to the patients there. The second thing is we need to look at really simple things to change the outcome. And so the the whole concept of failure to rescue and postoperative surveillance is a very simple one. But really, the biggest learning we had is, unfortunately, it's not like giving a drug. It's not like giving an antibiotic and the patient will be better, or giving a beta blocker and the ischemia will stop. Which has shown us actually that it's quality improvement, but I still think the principle is important. And so, but there's so much heterogeneity across our systems, but we're all ultimately dealing with the same problem, in that we don't have enough physical resources and we don't have enough human resources, and that the patients present predominantly late, unfortunately. So I think that is consistent. So we have to look at general principles which could be applied. And I'm sure in the critical care environment, it's exactly the same there, that there must be some very simple things one can do to make a change, which theoretically would have a very big impact generally. And so my principle has always been about generalizable change. And that's what I would advocate.
Thanks, Bruce. Very, very good. Happy to brainstorm further with everyone on this call. The intervention is not so easy to define, but a lot of learning from you guys. Thanks a lot.
I think, all the work that's been done with the EECC group, which I presume you are one of the key people there, that's a big network, done really good work, set some really good standards, and really a great place to start. And another thing that we also did quite early was engage the network in trying to find out what people thought were research priorities. And I think asking, a big network like that, where do you think the low-hanging fruits are? How are we going to address these low-hanging fruits so we can provide a generalizable intervention would be a good place.
Thanks a lot.
Thank you very much. Thank you, Professor. I am getting a message saying it is afternoon in Ethiopia, and I think everybody would like to have a tea. So yeah, for me, I think I need to go to bed. I spent the whole night up. So we are going to take a break for the break is I'm not sure, 15 minutes or 30 minutes. Yeah, it's going to be break now, and then we will reconvene by after 30 minutes. After 30 minutes for the next speaker. Thank you very much.
Thanks very much.
Manchera finita.
Good afternoon, everybody. Is everybody back? Okay, should we start? I hope you're having a very nice Saturday, and I hope every session has been informative. My name is Dr. Gannat Kifle. I'm an emergency and critical care medicine specialist, currently working at Alert Comprehensive Hospital. I'm also the emergency and ICU director there. To say a little bit about our hospital, Alert Center is has identified acute care medicine as one of its focus areas and is working on that specific area. And we've also housed one of the few trauma centers in the country, and the newly renovated ICU has just started working. So we have a training center, and we provide skilled trainings and refreshers for the staff at our center, and also people from different walks of from different parts of the country. We strive to become a center of excellence in acute care medicine, and the other interest area, our other interest areas are plastic and reconstructive surgery, spine surgery, and rehabilitation. So I wouldn't take that much time. It's my pleasure to present the next speaker, Dr. Mamba Sultan Mohammed. He is an associate professor of emergency and critical care medicine. He is one of the few intensivists in the country. He's currently working as director of critical care services at St. Paul's Hospital Millennium Medical College in Addis Ababa, Ethiopia. He's the president of the Ethiopian Society of Emergency and Critical Care Medicine. Dr. Mamba has led and consulted on numerous national emergency and critical care projects in the country. He's the founding member of the Pan-African Journal of Emergency and Critical Care. He's particularly passionate about developing evidence-based health care system in the country and elsewhere in Africa. Recently, Dr. Mamba has collaborated and published the first Ethiopian National and Critical Care Capacity Assessment, which helped in identifying gaps and gave baseline experience for conducting nationwide interventional collaborative studies in acute care. Today, Dr. Mamba will be speaking about intensive care in sub-Saharan Africa, results, experiences, and lessons learned for future projects. Questions will be asked later on. So, Dr. Mamba, if you can continue.
Thank you, Dr. Gannat, for your kind introduction. Good afternoon, everyone. Can you hear me?
Yes.
Okay. Thank you. So I am presenting on the findings of the National Critical Care Capacity in Ethiopia and what tried to be done in improving the situation in Ethiopia. And one of the effort was the mentorship and coaching program. So I'm going to present that findings also. In my outline, I am going to speak few words on the backgrounds of Ethiopia and critical care in Ethiopia. Then we'll come back to the results of the National ICU Capacity study and the role of locally driven clinical mentorship and coaching program to improve the situation in Ethiopia. So Ethiopia is an East African country, as you know, and probably some of the participants are from abroad. I'm just telling the backgrounds of Ethiopia. So the population of Ethiopia is around 114 million. And now it's 11 regions. When the study is being conducted, we had 10 regions and 2 administrative cities. And the life expectancy of Ethiopians has increased. It was 45 in 1990, and now in 2022, around 64 years of life expectancy. And with epidemiologic shift occurring in Ethiopia, there is also demographic with the demographic shift occurring in Ethiopia with increasing life expectancy, and there is a demographic change, like non-communicable diseases are becoming common now in major cities. 52% of deaths are becoming related to non-communicable diseases, and sudden deaths are mainly related to cardiac origin, and emergency care and surgical care demands are also increasing, while the communicable and pregnancy-related diseases are still existing. That means in Ethiopia, we are having a triple burden diseases, both communicable, non-communicable disease, and trauma and emergency. So the government is investing a lot to respond to this need, and the tertiary care hospitals, tertiary care facilities are increased, and specialty care, super specialty cares have increased, including transplant service, kidney transplant and all. When you come to critical care service in Ethiopia, the history of critical care starts in 1956, then called in Lelt Tsahai Hospital. That means currently it is called Torailoj Hospital, and it took us 7 years to open the next ICU in Black Line Specialized Hospital. By that time, Black Line ICU was established to manage septic shock caused by abortion and malaria, severe and complicated malaria patients. And currently, the epidemiology of patients being managed in ICU, the reports from Jimma, St. Paul's Hospital, Black Line Hospital, and Dese on the Mekelle, most are consistent, and they are managing sepsis, trauma-related head injury, obstetric complications, surgical emergencies, and communicable diseases still. So most of the diseases are treatable, and the age of the patients being admitted to ICU are younger as compared to the Western. Even in COVID, the average age for patients admitted to ICU and days is almost 57 years in Ethiopia, while in a Western nation, it is around 72 years, and some centers it is 80 years. So our patients are younger and having treatable patients. So the investment on critical care is cost effective or mandatory. So the demand for critical care has increased because of COVID recently, and there is a positive data in ICU capacity in low and middle income countries, including Ethiopia. So we don't know what is our capacity in Ethiopia, especially during COVID. Are we ready to manage the surge in ICU demand because of COVID? That was a question which was raised during the early 1920s. So 2020s, that means. So the objective of that, the national assessment, was to assess the baseline information on the status of critical care service and the structure, the staffing, equipment, and academic activities in the ICUs, and to identify and prioritize focus area for the scale up of critical care service in Ethiopia. So the method we used to assess this was it is a cross-sectional descriptive study using a hospital-based study, and it was from September 1 to September 14, 2020. And the survey tool was adopted from the Critical Care Society, which was developed for low and middle income country, with some modification to adopt it to our country. And 22 trained data collectors were recruited to deploy them all over Ethiopia, and funded by Ministry of Health, and IRB was obtained from Debre Birhan University, and the permission was obtained from all hospitals, and the descriptive statistics was done. So the result, at that time, we had 53 hospitals providing ICU, and 2 of them was totally dedicated for COVID. And so that time it was difficult to involve them, and we involved 21 ICUs in Ethiopia, which was close to 95% of the ICUs in Ethiopia, most of the ICUs were located in a teaching hospital, almost half. And the beds during that time, it was 324 beds for a population of 114. That means almost 0.3 public ICUs per 100,000 population. We didn't include the private ICUs, and this is almost just during the start of COVID, and the effort has increased and the number of beds has increased after that. Most ICUs are concentrated in bigger cities, in major cities, and 1/4 of the ICU bed was located in Addis Ababa. When you see this table, almost Addis Ababa has 10 ICUs. 2 of those ICUs dedicated for COVID was also in Addis Ababa. So almost 12 hospitals were having ICU in Addis Ababa, then followed by Oromia, Amhara, accounting 9, and the total bed in Addis Ababa was 81. So the highest number of beds located in Addis Ababa. While in some regions, the number of beds were low. Some in Afar, Redwa, they are having only 1 ICU, and some of the hospital, like in Somalia, they are having only 4 ICU beds during that time. So most of the ICU capacity were being concentrated in ICU. You can see from this map also, most of the ICUs were concentrated in central part. Even in Oromia, most of the ICUs are located in highlands or central parts of Ethiopia, even in being in Oromia region. So regarding the ICU equipment, the availability, almost 63% of the ICUs beds are having only the suction machine. So they are having shortage in suction machine also. And the 3 basic recommended non-invasive monitoring, like blood pressure apparatus, pulse oximetry, and ECG, is available only in 33% of the beds. So patients or beds are sharing this equipment for monitoring purpose. Limited capacity for ventilation that time, and invasive monitorings are only available in 3% of the centers, and renal dialysis is also available in only 8% of the ICUs. And the ICU bed had only 85% of the ICU have cylinders. This was a problem in most remote hospitals. The only central oxygen being functional at that time was St. Paul's, only 1 hospital. The others were using cylinders, and they were filling oxygen in major city and transporting to the respective ICUs. And most mechanical ventilators were available in Addis Ababa. So regarding the equipment, so ECG is available in 96% of hospitals. The ICUs also have ECGs, BP apparatus comparable. Pulse oximetry available in the hospital, but when you compare to the beds, it was low, and most equipments are available rarely in the hospital. Oxygen pipes were also rarely available. When you see in regions, so as you see in Addis Ababa, the total ICU bed capacity is high in Addis Ababa. The number of ICU beds is also high in Addis Ababa. So there are beds without monitoring capacity in Addis Ababa. When you have bed also, the monitoring capacity is low. In most centers, they may have the monitors, but most monitors were not functional, or they are not completely functional. That is why these centers are lacking, these beds are lacking monitors. When we come to the design and structure of the physical space, we were comparing their design and structure of physical space, comparing to the standard, which was the 12 parameters set by the International Federation of Intensive and Critical Care Medicine. When you that federation has classified ICUs into 3. Level 1, level 2, and level 3 ICUs, and there were 12 criteria to fulfill for level 1 or level 2 and level 3 ICU. Most of our ICUs are in level 1, and 9 of our ICU are in level 2. So actually, none of the ICUs were delivering level 3 ICU care. So, and most of the ICU were having less than 6 beds. As you know, less than 6-bed ICU are not cost effective. At least we have to have 6 bed in our ICUs, but 29, almost more than half of the ICUs were having less than 6 bed. Regarding the availability of a skilled medical professional, more than half of the hospitals have no critical care trained senior, especially they are not dedicated to ICU. And even though most ICUs are having one-to-one nursing to patient ratio, but most nurses are not having critical care training in their undergraduate training. Even medical professional doctors were general practitioners were not having critical care training in their undergraduate training. So there was a skill gap, and the other is most of the physician, critical care trained physician, more than 50% of the Ethiopian capacity were located in Addis Ababa. So they are concentrated in Addis Ababa. And the respiratory therapists, physiotherapists, and nutritionists were in none of the ICUs. These professionals were dedicated in the ICUs. Some 9 hospital reporters they have in the hospital, but these professionals were not dedicated in the ICU. So most of this job is expected to be done by the nurses in our ICUs. And only 7 hospitals have regular academic activity for their staff, and almost 80% of the hospitals have no infection prevention control or a program to monitor the infection prevention practice. So they had some of the hospitals have no access for hand washing. They have water, but most of them have not continuous water in their ICU. And some of the hospital, almost 55% of the hospital, have no separate and clean and dirty utility room. And the QI project is not available almost in 80% of our ICUs. So as you see, mostly the critical care baseline assessment was not promising. It was low. So there is a need for expansion of our ICUs. Of course, most sub-Saharan African countries have less than 2 bed per 100,000 population, except like South Africa and all. Uganda have lower than our 0.3 beds per 100,000 population, but most other countries have higher beds than ours, including South Africa, which have 8.9 beds per population, per 100,000 population. You can see like Germany have close to 30 ICU beds per 100,000 population, and South Africa has, as we said, 8.9 beds per 100,000 population, but we are having almost 0.3 beds per 100,000 population. Recently, we are close to 0.4 beds per 100,000 population. So there is a need for capacity building to train and the training of clinicians and nurses. This can be with short-term trainings, mentorship and coaching, and the spoke and hub model, so that the local better ICUs can help the smaller ICUs, and improving the availability of essential equipment and supplies. So this needs investment. And even though Uganda is having lower beds than ours, they are having more equipment and renal replacement than our ICUs. And we need standard policy and guidelines for the standardization of our ICUs and monitoring of our ICUs. And we have to redesign the structure of our ICU. So how can we change this situation? So the situation was very bad. So there was a huge effort from government and Ministry of Health, especially Emergency and Critical Care Directorate, to change this situation, because there was a pressing need and need from COVID care from a surge from COVID. So one of the methods selected was mentorship and coaching. So we will see whether mentorship and coaching is working for Africa or resource limited setting. The other method was spoke and hub model. What we did was selecting a better ICUs and connecting them with the smaller and worst ICUs, so that they will help each other during referral and equipment sharing and knowledge sharing. This was the effort, and we haven't done the assessment whether it was working or not. And the other was purchasing of equipment. So there was a huge investment to purchase mechanical ventilator and other all equipments from government side. The other is improving oxygen availability. So in all direction, almost doubling of the oxygen production of the country, and 20 ICUs were being opened since this assessment. Essential equipment was purchased for these 20 ICUs, and they were opened recently. The other is training of short-term training of general practitioners and nurses, so that they can function in ICUs. So among these, we were interested to assess. The other effort was collaboration work, increasing government focus, and there was a global fund, non-governmental organization, support from hub hospital, those hospitals who have a better capacity, and the professional societies also supporting, including our society, emergency and critical care society. So we were interested whether among all the efforts, whether the locally driven clinical mentorship and coaching, which is implemented by Ministry of Health with huge investment, whether that effort is improving the advance of critical care service among those smaller ICUs. So mentorship and coaching by definition is on-site training system under which a senior or more experienced professional, so that assigned to act as advisor or shadowing the clinical activity in the junior professional and the smaller ICUs. So as we have seen from the baseline assessment, Addis Ababa has a large amount of emergency and critical care or ICU trained professionals, including nurses. So this professional can mentor and coach smaller ICUs, so that those smaller ICUs become a better in a better situation. So there was a support from non-governmental organizations, including JAGPAEGO, Global Fund, and professional societies, but mainly this was the project from Ministry of Health. And whether this mentorship and coaching was really working or not was not known. So we went to assess the role of locally driven, because we are not getting experts from Western nations and all. Locally driven, those professionals who were working in Ethiopia and know the problems in Ethiopia, and coaching and supporting those smaller ICUs to improve critical care situation in Ethiopia. So the study design was mainly qualitative study with in-depth interview of the Menti hospital leadership and observing the ICUs from baseline to the end of the mentorship period. So the 31 ICUs were included during that mentorship period, almost 6 months period. And Menti hospital was selected by the baseline assessment, which I have presented earlier, and 24 ICUs were assessed whether this mentorship and coaching is working or not. So the role of the mentors were identified, and a one-day training was given how to perform a mentorship program. So these mentors were critical care trained physician and master's level nurses were selected from the mentor hospital, mainly in Addis Ababa, St. Paul's, Black Lion Hospital, and other hospital who are working in Addis Ababa. And they were deployed to this Menti smaller hospital for 2 weeks. So the role of the mentors were daily round. They will do round with doctors, and senior nurses were doing round with the nursing team, and they were shadowing the clinical activity during all the working hours and off working hours also. And they will work with the quality assurance team to identify root cause of the selected problems and make sure these selected problems were understood by the quality team and the hospital, and there will be a culture for a change, for future change after the end of the mentorship program also. And these mentors also will do daily systematic audit of the randomly sampled patient record and communicate with leadership, including the regional leadership, the Federal Ministry of Health, and the hospital leadership, so that there will be infrastructure change and they will get leadership focus. And they did short-term training on identified gap, and during the exit plan, they will write a detailed plan of a role of the hospital, the role of the Federal Ministry of Health, and the role of ICU, so that they will accomplish or do to change their ICU situation. So data was collected by interviewing the hospital and the ICU leadership at the end of the mentorship program, and follow-up visit or site observation of the ICU. And the interview guide was mainly with those 12 parameters adopted from World Federation of Society of Intensive and Critical Care Medicine. So data was analyzed thematically. So mainly 4 themes were identified and presented here. One of it is the impact of the mentorship and coaching program to improve the ICU care, mainly those 12 parameters selected from the International Critical Care Society. So, and the other is its role in leadership and quality of care, and the other theme is impact in utilization of ICU equipment, and the challenges were the selected themes from the qualitative study. So the impact, almost the 12 parameter, it's not all in all hospital, but at least in some hospital, all the 12 parameters were improving. The agreed academic activity for nurses and doctors and clinical rounds were strengthened, and most hospital reported the confidence level of staff to manage patients have improved. And the quote from one hospital, it has been 1 year since we have opened our ICU, and we have decided not to intubate patients, but now we have started it. They said there was no patient before almost within a 1 year which have extubated from that ICU. So they differed intubating patients. Then the mentor team has increased the capacity of the ICU, and their confidence level has improved, and they started intubating patients. So they also reported intensive care unit design was improved. So one of the quotes, this ICU wouldn't have been opened if the mentor team came to our hospital. So there are hospitals which opened the ICU after the arrival of the mentorship, the mentor team. So the Hamuz hospital also increased from their beds from 4 to 10 bedded ICU. So this happened with the technical support of the mentoring team. The other is the leadership and quality service. So there are lots of points raised by the leadership. Some of them are establishment of multidisciplinary team, leadership focus to renovation of ICU setup, improved bed capacity of the ICU setup, the IPC practice, and human resource demand forecasting and allocation. Most of the parameters have improved, but this is not quantitative study, but it has impact on this leadership and quality service. And some of the quotes from regarding the leadership and quality service. So they say we had documents involving protocols and guidelines, but utilization was difficult until all understood their impact. And the other is like infection prevention practice transformed from non-existent and to segregation of waste and to separate utility room. So most the leadership and coaching, the leadership and quality service has improved because of the mentorship and coaching. The other is improvement in utilization or operating critical care basic equipment. So there are equipments which were in the store, which were not being used by the ICU, while they have it in the hospital because of the lack of capacity or confidence in utilizing those equipments. And they have got trainings in how to operate ECGs, defibrillator, mechanical ventilator, infusion pumps, and the like. And they say mentoring and coaching program has helped to exchange equipment among each other. So there are hub hospitals or mentor hospitals which were exchanging or delivering equipments to the smaller ICUs, and there are smaller ICUs which gave some equipment to the bigger hospital even. So we started to use mechanical ventilator only after the mentoring team came to our hospital, is one of the quotes from the hospital leaders. The challenges reported was one is a budget constraint because those hospitals need lots of purchasing consumables were difficult, equipments, and also the mentorship and coaching also requires huge amount of money. That was a budget constraint. That is why the mentorship and coaching was only for 2 weeks, and demanding equipment and supplies donation from mentors. So mentors went to that hospital for mentoring and coaching, but some of the leadership were expecting equipment from the visiting team. The other is limited stay of mentoring team, like they were staying for only for 2 weeks, and it would have been better if they stayed longer time. The other is limited supply and equipment for the team, and the other is location of ICU. Some of the ICUs were located remotely, and consumable, including oxygen availability, was difficult to expand those ICUs because those cylinders were being filled almost hundreds of kilometers away from the ICUs. So those ICUs should avail their oxygen transporting 100 kilometers. So that was so difficult to expand some of the ICUs. These are my the themes we identified, and I think this is the end of my presentation. Thank you very much. So if you have question, you are welcome, and thank you. Back to Dr. Garnett.
Thank you, Dr. Mambo. I don't see any questions in the chat box, and nobody raised their hand. But I have a question of my own.
Yes, continue, Dr. Garnett.
Okay. So I was looking for people who raised their hands, and okay, I should go on. I wanted to ask, as you have found significant gap regarding human resource, is there any plan in advancing critical care service or intensive care training as a fellowship or postgraduate program?
Thank you, Dr. Garnett. As you mentioned, there are ways of improving critical care human resource capacity in developing nation. One of it is incorporating critical care in undergraduate program, and the other is short-term training for both junior doctors and nurses. But at a country level, we have to have advanced critical care training as a fellowship program. So it is not related with this assessment and the effort to improve this assessment, but Blackline, Addis Ababa University has started the fellowship program, and St. Paul's Hospital did a need assessment to improve critical care program and almost finalizing the curriculum. I know these two hospitals are going to start critical care fellowship program in Ethiopia. Hopefully in the coming months, we will see fellows in Ethiopia. Thank you for raising that.
Anybody else wants to ask a question? Okay, Munir, you can continue. Munir.
Okay, sorry, I had difficulty in unmuting. So thank you, Dr. Mambo. So I'm Munir. I work at Ministry of Health as a senior technical advisor, and so I know about this QI project, and it's a very good project. And so one of the things, COVID was a challenge, and at the same time was an opportunity, so that we were able to get extra resources we can spend on improving the quality of care and also access to care generally. But saying that, so improving quality of whether it's acute care or surgical process, and QI is, so there are some advantages and disadvantages that we can do. One of the things is that, so just to comment first on the assessment. So we have been doing assessment of the healthcare in Ethiopia and other countries, and most of the assessments have been assessing the input level. As earlier, as they have said, on the Danabedian model, there is an input to that to the work that we do, the human resource, equipment, supplies, drugs, finance, data, and so on. And there is a process of care, and there is the outcome of care. But so in the future, what QI generally has seen is that most measurements in the input, even if we can expand our services, there is always going to be a gap in human resource. Even if you go to high-income countries, they have always a problem of inputs. So inputs should not be measured to assess quality of care. So rather what we should measure is the outcome of the care. And the outcome has three components. One, what is the mortality and morbidity of common disorders in these ICUs? That's the most important outcome that we would be happy to know in these 300 ICUs. What is the mortality from, I don't know, sepsis, hemorrhage, and so on. And the other is what is the user experience here in these facilities? Are people being treated with dignity, respect, and so on? And the last one is, so how is the cost of these facilities? Are people selling their cows, which they used to plow, or their houses to get these services? Are the most important three endpoints. And there are some process indicators that as well. So any assessment that you do in the future should focus on the quality of care rather than access to care. Even though access is important, as a poor nation, there is always going to be a gap in access, and the number of facilities and health workforce and so on can show problem to access. But as earlier it was mentioned, nowadays, most people are going to be saved by improving quality of care, or equal number of patients can be saved by improving quality of care than improving access. So your assessment was great, but so when we do next assessment, we should focus on these outcome indicators so that we show that even if there are 300 something ICUs, so people who can have a preventable days could die even in these facilities would be an important finding. And the other is, even though quality improvements are important in improving quality of care, at a grand scale, they are not enough. So we need to focus on producing competent and motivated health workforce, as earlier said, not only giving them training after graduation, and having so there are several other steps that we need to do besides quality improvement. But quality improvements can be a very good tool for associations, for hospitals that can link with others at meso level, at regional health bureau level, at this level. They are, I think, a very good tool. But saying this, I think this was a very good opportunity for also ministry to strengthen the critical care management using the resources from Global Fund and others that were found during COVID. Thank you, Dr. Mambao.
Thank you, Dr. Munir. It was a very good comment. Most of them are comments which we accept. After this assessment, the one I presented with EPHI team, what we did was assessing the quality of care with individual patients, like you recommend. I think I don't have that data to present, but even Emergency and Critical Care Directorate and EPHI has also changed the way of assessing care from input to outcome level. So that comment is well accepted, and it's being practiced in these authorities, and thank you for that also. So the other, I think most of them are comments which we accept. Mainly you raised on cost issue, which was which is becoming difficult currently, especially in private centers. The cost of ICU is too much, which most of the Ethiopian patients are not affording. Even in government hospitals, the cost is becoming expensive, especially in ICU. I think even in trauma patients, when they are being admitted to ICU, whatever the insurance level is not covering which is needed in the cost in ICU. So that part should be worked on, and we will take those assignments. Thank you for your comments.
Hailu has raised his hand. Hailu, continue.
Thank you, Dr. Membao. So as insider, I'm going to ask a question. I was fortunately part of this exercise, and it was an exciting time because it really mobilized the resource that existed in each facility and also activated most of the leadership movement. My question is regarding the sustainability, because most of the team stayed there just for 14 days. And with that time, like with the team coming from the center, having the support of the ministry, obviously facilities would mobilize whatever resource they have, and the attention of the leadership at the facility will also increase. But I'm just worried if this is just Hawthorne effect, that's just excitement raised with what is going on because they are under observation, and with time that those challenges you raised are not going away, and the frustration is there. It was so palpable. We saw that, especially with remote facilities. So, is there any possible suggestion of a strategy to kind of localize such kind of mentorship or coaching programs so that it could be continuous? I know it is difficult to go from the center to mobilize that much of professional resource. It is really expensive, but is there any possible design connecting them to the local available institutions such as university, hospitals, and networking of other small hospitals?
Thank you again, Dr. Hailu, for this important question. Regarding the sustainability of mentorship and coaching program, I'm not sure the availability of funding for this program, but there is an interest. But I know there is a spoke and hub model where the hospital are being connected, bigger hospital are being connected to smaller ICUs, like the bigger hospital selected, I remember, Jimma University Hospital, Bahar Dar University Hospital, such hospitals where, and our hospital, St. Paul's, also having four ICUs, working or functioning as a hub for those ICUs, so that we will have knowledge sharing and sometimes equipment sharing also. We have seen one of the hospital near to Jimma having excess monitors, excess ECGs, but they are lacking some equipments, and they were sharing with Jimma University Hospital. So there is effort to implement a spoke and hub model, selecting hubs with a bigger ICUs and connecting them with the smaller ICUs as a spoke. There was an effort, and I was part of that. But whether that was effective and being continuously monitored, I'm not that much sure. But I know there were selected hubs, and it was functioning. If I answered your question, Dr. Hailu.
So Lam asked the same question. I think you've answered it now. The other question is, is there any action / implementation you have done based on the results to improve the capacity? This is a question that I found on the chat box. Should I repeat it?
You said action, depending on the findings. I think most of the action, including extensive training or short-term training, is all over Ethiopia. Investment to expand more than 20 new to open more than 20 new ICUs, and all mentioned were depending on this finding. I think there was a huge focus, whether it was from this ICU assessment or because of COVID. We have to work on it, but there is a huge effort after 2020 to improve Ethiopian critical care society. So the other question I saw from chat box is, do you assess other professionals that were assigned in university for teaching level? I'm not sure this question.
Could the person who asked the question unmute yourself and ask it again, if it's possible?
So one of the questions from Malkamo is a professional mix, non-physician like anesthetists. Anesthetists were almost the main part of those smaller ICUs. They were the main part in intubating patients, and they were involved in a training. So they were part of the assessment and part of the work. So I think that is the answer. And if there is another question.
Nobody else has raised their hand, but there is, I think, yeah, nobody raised their hand. So if there's no question, should we continue? Okay, there's another one. Were there any graduate in Cascade to other centers? If it's still a work in progress? So nobody raised their hand. So we continue to the next presenter.
Dr. Gannat, sorry, there are 2 hands.
Okay, I don't see them.
Dr. Munir and Malkamo is raising their hand.
Okay, Dr. Munir, I think. Okay, Malkamo.
Okay, so it's Malcolm actually.
Sorry, it's Malcolm.
Okay, can you hear me?
Yes, we can hear you, Malcolm.
Okay, so thank you, doctor, for your presentation. I think you mentioned a little bit about non-physician anesthetists and their availability in those lower ICU setup. And I'm also part of that setup. So my question was, what can we do as a non-physician anesthetist to improve this critical care setting? Because there are lots of red tape that prevents us from actually helping this patient and participating in critical care, although might require some kind of training. Just intubating this patient and giving a small amount of help might not be the most appropriate way to help them. So is there any setup, any agendas or from the Ministry of Health or from your research that can help us improve our participation in this critical care setting? Thank you.
Thank you, Malcolm, for your clarification. This important question. You say, at the beginning of the implementation effort in to improve this ICU care, the first thing was training and involving anesthetists in this program. So the problem identified at that time was most anesthetists in their center, they come for intubating the patient, but they were not being involved in medical care of patients in the ICU. But in most places, they are the only one to help those patients during difficult time, including airway care. It's not only the airway care. They have to understand the medical care of and manage medical part of the critically sick patients. So we involved them in a training, in short-term training. That may not be the only solution to involve them, but in all their centers, they have to be part of the ICU. And that was also what, to my understanding, that was also the direction of the Ministry of Health. But if you ask me in my experience, most anesthetists are not being fully involved in medical care of patients in ICU. They come for airway care or when there is airway difficulty, but I think they have to be integrated in a medical care. In some hospital like Eka Kotabi at the beginning, what I remember is they are part of the ICU, they make round, they will be part of the decision process in ICU. This culture should improve. How can we improve? I'm not sure the exact answer. What we did was they were part of the training in all short-term trainings in ICU. But it should be a culture to involve anesthetists in the ICU practice, especially in those smaller ICUs, because they are the backbone and they are the only one available in those ICUs to help those patients. Thank you.
Okay. There are other questions, but I'll get back to them later because we have another presenter. And if you have any questions, put them on the chat box and we'll get back and Dr. Mamba will answer your questions later on. So the next presenter is Professor Rupert. He's already introduced earlier, but he'll be talking on building local and acute care research capacity and integrating research outcomes into national policies, lessons from the UK and other developed nations. So, Professor Rupert, if you can take the stage.
Thank you very much. So I've been asked to talk a little bit about how we can translate learning about building research capacity in acute healthcare into a global health, low middle income country environment. And I think probably the overriding principle that I would say is that the principles, the main theories are, I think, the same everywhere in every type of country. The challenges you have are obviously more severe in some countries than others, and some hospitals than others. And the combination of different types of problems is obviously unique to each hospital, but the overarching principles are the same. And that's important because it means the solutions to our capacity issues can be worked through based on the principles that we've used in other countries. So I think that this is one area where we can be confident that we can share knowledge between high-income countries and LMICs. So the first big principle that I think in particular applies to anesthesia doctors. We're backroom people usually. We're not at the front of the stage. We're not the centre forward on the football pitch. We quietly work in the background, and that's our nature. And so we're not used to walking to the front, taking control and saying, right, this is what we've got to do. This is the problem, even when we can see what that problem is. And so I think for us as a group, we need to remind ourselves that if we see a problem and nobody else is taking the lead in tackling that problem, then we shouldn't be afraid to do that ourselves if nobody else is. Because rather than be criticized or people disapproving of what we do, you'll almost certainly find the majority of people are glad for you to step forward and glad of your contribution and that they'll value that. Not everybody will. Unfortunately, in research, we do find sometimes that our colleagues are jealous of what we're trying to do or maybe critical of what we're trying to do because maybe they wanted to do it and they didn't know how. But I don't think you should let that kind of thing stop you. So please don't be afraid to take the lead. Second big principle is how you build your collaborations, that team of people you work with. And it's really important, and I think in particular, it's really important for me to work with people I trust. I have to know when I am involved in projects that are really trying to be world-class in terms of the impact that they have. Average is not good enough. We need to go for really, really high quality research because our patients deserve that. And that means that we're always striving for excellence in the work we do. And that extra pressure means that you have to trust the team around you. But the big caveat to that, the big caution, is that in the great majority of cases in people I've seen where there is a breakdown in trust in a collaboration, it's not so much that people weren't trustworthy. It's much more common that people didn't learn to trust others. So there was a suspicion of one person from another that didn't have any basis. There was no reason not to trust that other person, that they weren't trusted. And so I think that as well as working with people you can trust, I think it's very important to learn to trust those around you and learn to trust their intentions and recognize that when you've got really important shared goals, just because you may try and tackle that problem in a different way doesn't mean that people can't trust each other. The next big area is about how you engage and manage senior collaborators. And this is an important area because in many projects, more junior staff will want to bring in a senior colleague, either from their hospital, from their country, or maybe an international collaborator. And there's an art to how you collaborate with senior people. As a general rule, good senior collaborators don't mind if you manage them. They don't mind if you organize their time. They don't mind if you give quite clear guidance to them on what you expect from them and what you need from them, because they find that helpful in terms of, they don't have much time available. They don't have much time to work those things out for themselves. So the clearer you are with them on what's expected, the easier it is for them to know, first of all, that they've got the time available to help you. And second of all, that they're doing something for you that you need. So don't be afraid to be quite clear with a collaborator that I'm bringing you on board to do a very particular task in a very particular way, and or I'm bringing you on board just to give us advice, and you don't need to do anything unless I contact you and ask you a question, or whatever that might be. The other thing about senior collaborators is that some researchers have a tendency to collect them, as if by having lots and lots of senior collaborators, it will somehow generate recognition that your project is of a very, very high quality. But actually that doesn't normally turn out to be the case. And it's much more likely that if you have lots of senior collaborators who aren't very active in your project, that will be considered a weakness, not a strength. So learning how you bring senior colleagues on board, how you give them particular tasks, and how you manage them so that they deliver those tasks in the way that you need is an art in research, as in all things, I think. And it's a good thing to focus on and learn about. My next comment, and I brought this up in my previous talk, and I think Catherine Chu raised a comment about it as well, is that we have a tendency as researchers to become very preoccupied with money and how much funding we have. And in my experience, although you always need some money, you can't really deliver research with no money at all. It becomes very difficult to do that. What you can do much more with is resources. And I think the ASOS study that was delivered out of Africa is a really fantastic example of that, because that project wasn't really delivered with money. It was delivered because people shared resources, whether that's local investigators and individual hospitals agreeing to help because they believed in the project, or whether that's because someone gave up their time to do the statistics, or whatever it might be. The majority of the ASOS study was run for free by people sharing really important resources. And so you're most likely to make progress by asking for resource, not asking for money. Now, that doesn't mean you can't do research with no money at all. That's not what I'm suggesting. Just that you probably need more resource and less money than you might necessarily think. So always consider, what do I actually need? I mean, if I'm asking for help, do I need to ask for money, or do I need to ask for the resource itself? Because often asking for the resource can be more successful. And applying for grants and seeking money can be very, very time consuming. And it's very easy to do more work getting the money than the work needed to do the research itself. The next big point, and I say this to my colleagues a lot as well, is organizations are made of people. So it's very common to hear people say, this university has decided this, the government has decided that, our hospital said this, as if those organizations were sentient beings that made decisions. But that's very unlikely to be true. What's much more common is that those organizations are built from people. People are the bricks that they consist of. And that somewhere within that organization, there is a person who's made that decision or is responsible for that decision, who you can engage with, who you can reach out to as an individual human being, who you can try and understand as a human being and negotiate with them as a human being. And that if we do that, we can often find that we can influence those people. So people who work in organizations often feel a very heavy weight of responsibility to support others. And we may think that's not true, but it usually is. And that sense of responsibility means that when people come to them for help, they want to help. And often when they don't help, it's not because they don't want to, it's because they're unable to, or because we've asked for help in a way that makes it difficult for them. So understanding those people, understanding how could they help me? What are the drivers in their job, in their role, that might make it harder or easier for them to help me? And by thinking about how you make it easier for them to help you, you increase your chance of getting the support you need. So thinking about people, not about organizations, I think is a really valuable approach. The next point is that success is the biggest driver for success. So if you have a small early success, you prove to people that you're capable of leading, you're capable of delivering, you demonstrate your work ethic, you demonstrate a whole range of things about you that are hallmarks of success. And if people see you and go, well, that person has delivered a small research project and they did a really good job, it was very successful, it was on budget, or it was on time, or it was really high quality piece of research, they're much more likely to be confident in you. And if they're confident in you, they're more likely to invest resources, they're more likely to share money, they're more likely to publish your paper, they're more likely to provide things that you need. So don't underestimate the value of a small success as a driver for the next bigger success. And often in research, you start small, you deliver something that is an easy win, and then you build on that easy win and go for bigger and bigger, more ambitious projects as you go. And in that way, small successes can deliver very, very large successes indeed. And I think that's a valuable way of thinking about building a research group. This is a lesson I have learned the hard way and the easy way on more than one occasion. When you're doing research, the data is the research. If you don't control the data, you don't control the trial. And I think we've heard this statement in various ways today. We've heard about international collaborators coming into our hospitals, doing research with a data resource that we hold locally, and perhaps not giving any credit to the people that have collected those data, or who perhaps are deserving of credit and recognition. I think Catherine made those points really well, and I think that's really great that she highlighted that. But remember that controlling the data is the way to control the way research is conducted. And if you hold the data and if you are the person who controls the access to data, it allows you to lay down rules about how the research is conducted. And that might be rules about quality. It may be rules about research ethics. It may be rules about your collaborators being professional and fair and equitable in the way that they work with you. So don't underestimate the power of controlling access to data. And remember that if you negotiate what you need in a research collaboration before you agree to share data, you're much more likely to get the things you need out of that research project, whether they're things you need personally or whether they're things that you need for your organization or for your team. Use every opportunity to demonstrate integrity. Reputation in research is everything. We live and die on our reputation as researchers. When we send our research to a journal and there is a question mark over some data, there is a problem with a paper, which are very, very common problems. That's not unusual, even for very good groups, to write a paper that there's a problem with. The first thing that a journal editor or a peer reviewer or really anybody will think is that researcher somebody who has a good track record of behaving in a very professional way? Are they honest? Do they have a track record for being open and sharing problems with their research, discussing limitations with their work in an open way, as well as discussing the strengths? Do not underestimate the value of demonstrating your integrity, which often means you are prepared to share and discuss the weaknesses in your own work, amongst other things, because it's a real strength, and you will develop a reputation and a track record for integrity, which people will value about you. And when there becomes a difficult moment with your research, they will trust you because they know and have seen that you behave in a trustworthy way over and over again. And so don't be afraid to demonstrate that. I think this is an important one. Don't confuse the research you can do with the research you need to do. Often we have a research question that's very, very important, but we don't have the resources to deliver that research. And so we design a project that's maybe too weak. It's not strong enough, it's not big enough, it's not robust enough to answer the research question we have. And it's quite important when we are doing that we recognize it, that we don't feel ashamed somehow that we need to pretend our research is robust when perhaps it isn't, because that's a common problem. It's better to accept the research is not big enough, strong enough, robust enough, and maybe go away and do a smaller project first. And as I said earlier, build on that success so that you can get the resources you need to do the larger, more difficult project that you need to do. And being open with yourself that maybe the research you propose is not the definitive research that you know you need to deliver. And instead having a strategy of delivering a series of small projects that lead up to a big research project, rather than trying to do a huge research project in one go. And in general, research is more successful if you take lots of small steps than a small number of big steps. Interpretation. When we do a research study, we all want to say that it's incredibly important. We all want to demonstrate the impact of our work by telling people that it's really shocking, or it's really important, or it's really exciting. Well, most of my research is quite boring. And I usually find that if I try and say it's exciting, I mislead people. I maybe highlight a finding that's not the main finding, or maybe I mislead people in what my research actually means for patient care. And it's not helpful to mislead people about what your research finds. Even if they can go and read it properly for themselves and work it out, they'll be very reliant on you as a researcher to interpret your research for them. So don't be tempted to try and have a big, exciting headline. If that headline is misleading in some way, because it can be very counterproductive for you, and it will cause you problems with your next steps in that theme of research that you're undertaking. I think another point, and again, this has come up more than once today, is to role model equity and recognition of your collaborators. Always make sure that you set your research up in a way that the little guy gets recognized, because big collaborative projects rely on local investigators in their own time, usually, giving up something else they might do. Maybe it's an evening with their family, maybe it's a day out with their children, to do research, to do work on your research project, and to recognize that valuable contribution, that sacrifice people have made, in particular through authorship or study group membership that leads to listing on PubMed, amongst other things. That recognition is incredibly valuable to people. And it's something that may not seem very important to us as research leaders. It sometimes means the world to somebody who's given up their time to help collect data in an individual hospital for us. And by creating a culture where all of those people get recognized for what they do and their contribution is recognized as invaluable, that we can't do without those people, then the more we recognize and celebrate them, the more they're going to want to come back next time and help us again. And amongst them may be some future successful senior research leaders. And we really, really need more research leaders everywhere, but in particular in low and middle income countries. Finally, dissemination. When we tell people about our research, sometimes there's bad news. And in particular, if you're a politician or a civil servant in charge of healthcare, if somebody does a research project, such as the excellent talk we've just heard, discussing critical care resources, there's some very honest and straightforward information there, but it's mostly not good news. It's mostly that we don't have enough resources and things aren't going well. There are some good news stories in there, but a lot of the story is bad. And you can imagine how a journalist could write a very negative newspaper article or a YouTube article about those findings. The best way of dealing with that is to go and see those policymakers, go and meet the politician, go and meet the civil servant and say, look, we found these things about critical care or whatever else it might be. And we think that it's really important, but we don't want this to undermine you. We want to work together with you to show that we're going to use these findings to make, you know, our hospitals better, our healthcare system better, the world a better place. And we want to work together with you to do that. That allows those people to use your research as a success story for them. It allows them to go, I'm happy to have this opportunity to identify problems with our healthcare system. And we already are doing these 3 things that are going to help solve the problem. It allows them to turn your bad news into qualified good news for them. And that means you build a relationship with them. That means they trust you. Most of all, that means they're going to help you implement your findings of your research and work with you in the future. So bearing in mind that it's very easy just to share a research paper before it's published and to talk to people about that. That can be an incredibly valuable approach in engaging policymakers. So I'll stop there. And again, I just want to highlight the fantastic successes of research in perioperative care and not only through the APORG group, but also through individual national collaborations. I think that there's some absolutely superb work going on. I'm delighted simply to be here to talk with you about it. And I'm really impressed, and I wish you every success with your next projects. Thank you.
Thank you, Professor, for the nice presentation. I'm looking for participants to raise their hand if there is any question. Please proceed. Thank you, will agree to participants with question. You've raised some interesting points in your presentation. Some of the things that I found interesting were, don't confuse the research you can do with the research you need to do. So as young people who are interested in research, we tend to be confused and just look at the things we can do when we don't even know if we need to do it. So thank you for that advice. And the other thing is don't fall for tabloid findings. So you're right, we tend to be overly dramatic in the findings, and the simplest things could change many things. So there's, I think there's a comment from Alamayo, Dr. Alamayo. Thanks for the insightful presentation. So any questions?
I think Bruce has got a question there.
Okay. So he can continue.
Thanks very much, Rupert. Thanks, Dr. Ganesh. I just wanted also to reiterate that I think, Rupert, the principles you've raised are super important. And the principle about tabloids and media and that, I think, is extremely important. My own personal experience with, the work with ASOS and particularly with the cesarean deliveries was, how do you get a message out that women are doing so badly, and it's so important without it being framed in the wrong way. And I know I had a lot of reporters wanting to report on it, but the whole time you could see they were looking for an angle to blame, which is extremely destructive. And my advice just to the group is, I think a lot of time when we do end up speaking to the media, most of the time, unfortunately, we're not going to have good messages. We're going to have advocacy messages. And just be careful that you don't get sucked into trying to ascribe things which you never actually studied, because that really will become the main part of their story and it'll be very destructive for the group. So one has to be very careful, and I think that point you don't really realize until you're almost in it. But fortunately, I think we've managed to steer clear of that as a group, and that's been very good for all of us.
Yeah, I agree with you. There's always a positive way of spinning a negative message. And the thing with journalists is to think about, every sentence, every little cluster of words. They don't take a paragraph of what you said. They take a little cluster of words, but always trying to spin things like, if you found something that there's a high mortality rate, you said we've got an opportunity to improve outcomes. It's always turning the negative into the positive. It allows you to avoid that particular risk.
I think, yes, you've got to appeal to their greater good, because you can see their normal modus operandi is the opposite. And you've got to say, this is really the good of society. You have to present this in a positive way.
Yeah, Salome has a question, I think.
Thank you very much. Also, congratulations to everyone for this excellent meeting. I just wanted to add as well to what Bruce was saying, and I found that in my experience, having recommendations ready and volunteering them alongside the problems, even before they ask for them, immediately diverts the conversation, and they're now saying, what can we do? What should we do? So I was just adding that, conversations with media, you direct them and go in there with answers, and not just the problem, but recommend. It's an excellent opportunity to give recommendations, because everyone will always will want to know what should we do next now that we know this. Thanks.
I couldn't agree more. And I think, of course, it's your opportunity to highlight the next step. You know, that media coverage. We should already be thinking about the next thing that we want to do, the next study, or how we're going to implement our findings. I completely agree.
I think we are finished with the question. Thank you, Professor, for the next presentation. We continue to the next session. I think it's a closing remark by Dr. Alenta.
Hello, everyone. Thank you so much for the wonderful session. My name is Alenta Gabriyesus. I'm an emergency physician and currently working as Director for Emergency Injury and Critical Care Directorate at the Ministry of Health. I'm also coordinating the current conflict-related health emergencies. I've had ground level experience as a clinician, educator, and have been part of several implementation research here at the ministry and outside. So it gives me great pleasure to be here, part of this session, and I would like to thank everyone for the lively and interesting discussions we had today. I mean, it's important and very practical points have been raised. It's been such a wonderful and fruitful discussions. I just would like to highlight or reiterate some of the key takeaways from the discussion we had today. Those points have been discussed one way or the other, but I just wanted to give some emphasis on the first one is knowing or identifying the priority areas for research in the acute care continuum in emergency, critical care on the point. So defining those priority areas would be key. The second one would be building local research capacity and meaningful collaborations with the trust and the meaningful collaborations between different collaborators here within the African setup or outside. The third one would be creating equitable research collaborations that are in line with local needs and producing sustainable results and value adding to improving the patient outcomes. We've also mentioned a lot on these areas. The prior speakers have mentioned valuable inputs in these regards. The fourth would be that translating evidence to policy and practice. And the fifth one would be continued advocacy and getting the message out there, reaching the wider networks in this regard would be, these are some of the key takeaways or highlights I took personally, and I hope the audience also took these key takeaways. So considering what is out there, what is the supportive environment out there? Is there one? I would say yes. And it's also starts from, it also ranges from the policy decisions and strategy level facilitations. So there have been several efforts by the Ministry of Health to integrate these areas and make these priority at the highest level, at the policy and strategy levels. As you know, the ministry has also launched several strategies, one of which is the 5-year National Emergency Injury and Critical Care System Strategy, which also highlights the need for evidence generation, evidence-informed decisions, and institutionalizing this culture. So yes, there's a positive environment for collaborative work from the ministry side. There are also several other strategies in support of this work. I would like to mention the ministry has also started this major city emergency injury and critical care improvement program, which mainly focuses on having a customized high impact interventions in selected cities, and this provides a unique opportunity for academia to collaborate between the academia, the regional health bureaus, the local administrators, including the political leadership, because we have to have the buy-in to implement those changes and have them in a sustainable manner. So I just wanted to mention that there is a great foundational work that is already available to build on and continue the research questions and taking these steps forward. my colleague Dr. Munir is also mentioning that there's also the ministry is also establishing a separate research unit within the research unit, which would guide the national efforts, the national priority setting, and facilitate such efforts. So that those are really positive environments we have. Apart from that, there are several surveys, national surveys that my colleague Dr. Mambao has mentioned earlier. These have been done in collaboration with the Ministry of Health and different societies and professional associations. So targeted mentorship and coaching, need-based assessments and supports are being done at national level. And of course, we're also working on the sustainability efforts and very open for inputs in this regards. Several guidelines, SOPs, hands-on trainings, capacity buildings are also in the pipeline. So just wanted to mention what's out there, which would fuel this collaborative works from the ministry sides and as well as in the acute care system. Apart from that, there are also numerous opportunities and possible opportunities for service for different stakeholders that have been involved in this, that are involved in this work so far. There are so many areas for improvement, and I also want to bring to the team's attention the area of this acute care continuum range to out of hospital and the pre-hospital care and the community needs as well. So I also would like to open this up as another research question to be addressed, because there's a dearth of and paucity of data and evidence in this regard, especially in the low and middle income countries and the African context. So I think the next steps should be well thought of, and we should also keep this momentum and take the discussions to the next level. And I would suggest we do have different stakeholders attending this conference. For the service providers and clinicians, I would suggest an increased focus in clinical effectiveness and cost effectiveness of care, designing quality improvement projects which would benefit their local institutions and facilities, and bringing those lessons learned out there so that the patient care could be improved, as well as the evidence could also be generated and scaled up to different facilities, and changing the daily challenge into unique opportunities for continuous quality improvement would be something to consider. For those working in academia, the customization of high impact interventions to suit the low and middle income context or setting, it would be very key, and it's very untapped. Designing of curricula for specialty programs, not only for physicians, but also for nurses, for anesthetists, other professionals working in the acute care system would be food for thought and something to consider. For institutions and universities, building on the collaborative area and also experience sharing, designing exchange programs, building local capacity, building the local capacity for research as well as grant writing, focusing on the financial aspects and cost effectiveness of care, because when we bring the sustainability piece into the picture, we still need to deal with such questions as well. And also, of course, as I've said earlier, extending the questions to the out of hospital or the pre-hospital context to avert the delays in perioperative setting, the critical care, surgical care, and also the delays in achieving the desired patient outcomes. And also, I would also like to call upon the several networks to really leverage these platforms for capacity building, sharing experience, and also obviously the conference organizers to have these key action points and have these key action points formulated, continue the discussions, craft for further collaborations, and also keep the regularity of such platforms, because these are very helpful and fundamental for growing for addressing the growing needs. And obviously, the Ministry of Health, would like to affirm that we have the continued commitment to institutionalize such efforts and use evidence for policy making and strategic decisions, and the guiding quality and sustainability of care we're very interested in conducting implementation research and implementation science. So just wanted to reiterate this and affirm the continued commitment from the ministry side. Last but not least, I would like to thank the all distinguished guests for your time, excellent presentations, for your invaluable experiences, and for your time. My appreciation on behalf of the ministry and my other colleagues. Also, I would also like to thank the participants for the lively discussions and participations, very important comments and feedback, and obviously the moderators for excellent moderation and facilitation of the sessions, and the conference organizers for making this happen. My heartfelt gratitude also goes to them. So I just would like to leave you with this challenge. I mean, what can we do with what we have, and how can we make the points that we've addressed in the path to contribute towards addressing the bigger picture of universal health coverage, protecting people from health emergencies, having a responsive and meaningful system which would address the needs of the individuals and patients. So I would be leaving you with this question, and it's definitely time to build African acute care research capacity as a priority in global health. Thank you so much for having me. Thank you. Over.
Thank you, Dr. Alinta. Thank you all very much for a wonderful day we had together. It was full of refreshing ideas. And thank you for the organizers, APORG and N4PC. We've finished our day one, and our program will start tomorrow early morning at 9 a.m. East African time. And we'll be hoping to see you all tomorrow. And unlike today, tomorrow's program will be half a day program. And see you tomorrow. Have a nice night.